Welcome to our 5th annual QU Health Research Symposium. I think we're going to start by welcoming remarks of Dr. Egan. Dr. Egan, are you there?
Yes, I'm here.
Okay, so go ahead.
Okay. Yes, it's a great pleasure for me, Faraz, that you want me to come and introduce this, which is your baby. We've been working on this for quite some time. Yeah, big baby. It's a growing baby. It's maybe not even a toddler anymore. It starts to getting more mature and more well developed. This is the 5th year, and this is actually because we started before we have finally got the approval of the cluster. So it's also showing that there's a lot of initiative and a lot of activities going on in the research area within the cluster, as we have already reached 3 years after we were born. So this is showing the initiative that is in our institution. I think it's a pleasure to have the opportunity to follow the development of the research. I don't like to put too strong phrases into something we're doing ourselves, but I think actually we're doing pretty well. The number of publications are really going up very fast. We have got more funding, and we have got this, you could say, really big, in my opinion, achievements that we have now united the 4 colleges in the wet lab research. So now we have this biomedical and pharmaceutical research unit. And this is a great achievement, because this is what we need to grow and to continuously attract more people, good people, more funding, and have quality of our research, that we can do things across the different disciplines. Faraz and Gahid, they made a small investigation into the other centers at QU, and I think our publications was twice as much as the research center producing the most publications, that is material science. So we are really strong. And then just this morning, I don't know if you've seen the emails, I thought we should maybe try to make a regional benchmarking. There are probably some Saudi units that have more publications than us, but I think on top of that, maybe we are following quite closely. So I think it's interesting to show our strength there. Also, we are in the introduction of trying to make a unit for the not the wet lab, which so far has the working title clinical and population-based research. And this is something we want to do together with the clinical colleagues we have in Hamad primarily. And this has just been initiated. And for that purpose, we have got the good possibility to hire, based on 50% funding from QU, researchers inside Hamad. And these will be really the bridge between the things we are doing in the basic research to the clinical research and the data for the clinical data we need from Hamad and CIDRA and PHCC. So it looks like in a few years we will have really a well-functioning research unit, and I want to thank you people in the research office. You're not many, but there are many who have been working really hard on this, and of course Michalis has done a great job in establishing the unit. So there's a lot of optimism, I think, in the research sector of the QU Health, and I hope we will have a very good day today. I look forward to see what you have chosen and what will come up. Thank you.
Sure, thank you so much, Dr. Egan, and thank you for your leadership and continuous support of research. I know it's been your goal since day one. Okay, so next slide. So this is next. Okay, as Dr. Egan said, this is kind of like among our oldest activity as a cluster. This is our 5th year. This has been always a platform to exchange and showcase our research and findings and discuss science through selected competitive podium presentations, posters, and workshops. If you remember last year in 2019, it looks like been for ages, but it was very vibrant. So many students and faculty joining us, and if you remember at Ashton, hopefully these days will come back soon. Also, we are fostering an environment for even some competitive competitions. So we are even offering awards for our best faculty, graduate and undergraduate students. So every year we select certain themes. So this year We picked cancer, cardiovascular, reproductive medicine, health professional education, and COVID-19 as well. Just to give you, we have received 25 submissions from faculty to present a podium. 8 has been selected. We also received 22 faculty presentations as a poster, 36 of postgraduates presentations, and 53 from undergraduates. Those being all recorded as a 3 minutes video, so you can access those. I'll show you about the link. Let me thank so many people who've been working on this. This has been almost now 1 year planning for this day. So working with me in organizing and scientific committee is Dr. Gerhard, Dr. Masha'il, Dr. Dawood, Dr. Asad, Dr. Fatiha, and special thanks to Ms. Sana Al-Ajuri as well. We have several judging committees. For our oral faculty presentation today, we have Dr. Anas Hamid and Dr. Pali Abdul Raouf from HMC, Dr. Nahla Afifi from Qatar Biobank, and Dr. Wadhal Muftah from Qatar Genome. We also thank our poster faculty presentation judges, Dr. Alauddin Mustafa, Dr. Bella, Dr. Karam, and Dr. Layla. Our postgraduate presentation committee, Dr. Abdullah Habib, Dr. Kazim, Dr. Hussein, and Dr. Nahla. Our undergraduate presentation, Dr. Atiyah, Dr. Hisham, Dr. Rayes, and Dr. Al-Aish. We also acknowledge our IT department, wonderful guys here, Mr. Bilal and Mr. Shuja. Also our communication and public relation people, Ms. Munira, Raneem, Saad, and Shayma. So I urge you to go to our website where we have all the information you need about the program and details of it. Also, you can access, the presentation, the recorded one, the 3 minutes video presentation. Our program today is mixed between, we have 8 short presentation as a podium, in addition to 3 invited speakers. One from QU, Dr. Hadi Yassin from BRC, where he's gonna cover recent development in COVID within Qatar and QU. But we're also having 2 distinguished scholars, Dr. Jennifer Cleland, from Nanyang Technological University in Singapore, and also we have, she's an expert in health education and the economics of it, the cost and value. We're going to hear her talk, and we're also having Dr. Shufang Chu from Peking University in China, where at the afternoon he will be basically covering all recent developments in COVID research and vaccination. So with that, I'll give the mic to Dr. Dawood. So Dr. Dawood Al-Badriya is our moderator for the session, where he's going to introduce our first external presentation.
Thank you very much, Dr. Faraz and Dr. Egan, and good morning all. Yes, our next presentation is basically the keynote session of today, which if you look at the title of it, Dr. Faraz, can you put the slide back, please? In relation to the session. Basically, yes, if you look at the title of it, you see basically it's made of 2 topics to be talked about today, both very relevant and hot topics: the cost and value of health professional education, or the cost versus value of health professional education, as well as health professional education post-COVID-19. And with this, I'm super excited to introduce our invited external speaker for this session, Dr. Jennifer Cleland. Now, Dr. Jennifer Cleland is a professor and is currently the director of the Medical Education Research and Scholarship Unit at Lee Kong Chian School of Medicine in Nanyang Technological University in Singapore. Now, before joining this position, not so far away, just starting in 2020, she was the chair of Medical Education Research and the director of the Center for Healthcare Education Research and Innovation at the University of Aberdeen in UK, as well as the director of the Scottish Medical Education Research Consortium. Dr. Jennifer is a psychologist by training, studied psychology at the University of Stirling before earning Master and PhD in Occupational Psychology from Queen's University, Belfast, and then also completed a doctorate in Clinical Psychology from Edinburgh. She was initially a clinical psychologist in liaison psychiatry, working with the UK NHS, before moving into full-time academia about 9 years ago in 2011. And now, with over 200 peer-reviewed publications in leading journals, Dr. Jennifer is an internationally recognized expert in medical education research. Her particular areas of knowledge are student selection, assessment performance, medical careers, decision-making, and education and system reforms. She's a lead editor of Researching Medical Education textbook, which is a core text for Master of Health Professions Education program globally. Dr. Jennifer was the chair of the Association for Medical Education between 2013 and 2018, and the chair of the Association for Medical Education Europe Research Committee between 2014 and 2018. She's an invited member of the Wilson Center in Toronto, Canada. She's an adjunct professor at the Uniformed Services University of the USA. She's an honorary professor at the University of Aberdeen in UK and in the University of Southampton in UK and in Curtin University in Australia. She's also an honorary fellow of the Royal College of Physicians in Edinburgh. So thank you very much, Dr. Jennifer, for joining us and for contributing to this event. Thank you very much for the, for the time spent on all this back and forth communication throughout a couple of months, at least with me personally, in relation to identifying the topics for this session as well as for tomorrow's workshop, which, as a reminder for everybody, is about publishing in health profession education journals. And it's only really unfortunate that we couldn't have you in person at Qatar University in this cycle of the event. Now, before I give Dr. Jennifer the microphone, just a note for everybody. If you are looking to ask questions as Dr. Jennifer is presenting, please send these clearly as text through the chat box for me, to the best possible, to go through them and share them with Dr. Jennifer when time is due for questions, which will mostly be by the end of each of the different parts of the oral presentation. And with this, without further ado, Dr. Jennifer, the microphone is yours. Go ahead, please, and share your slides. Thank you.
Thank you very much. I would have loved to have been with you all today, and in fact it was very disappointing when the original meeting was cancelled, which was obviously just with a few days notice, but the timing of your meeting and of course other meetings around the world was, nobody could have predicted what would have happened. So I'm delighted that you've managed to put this online so that there's the opportunity for sharing and learning. It's not quite the same as being there in person and meeting people, but hopefully there will be some interesting content in the talk I'm giving and in the workshop tomorrow. And please do ask questions. The way this is timed is I'm going to speak for about half an hour, perhaps slightly longer, on cost and value in medical education, then have a pause for questions, and Dr. Dowell will moderate that. Then we'll talk a little bit about COVID, and that will be a kind of reflective session, and in some ways it does follow naturally from cost and value, but there are other things obviously that we have to think about too. So without further ado, I will share my slides. I do always worry that things will go wrong with technology, and hopefully that won't happen today. So just to recap, I was based in Scotland for, most of my life. I worked in the UK in various places, or trained in various places. But I went to the University of Aberdeen in 2000. And the first job I had, for 10 years, I split my time between working clinically as a psychologist in the hospital and doing research and teaching and working on the medical degree. Aberdeen's a strange university in that it has medicine and dentistry, but until very recently, no other healthcare professional courses. A few years ago, a course started up for physicians associates. So we were kind of isolated from other healthcare professional groups, but there was another university in the city, Robert Gordon's University, and which offered all the other healthcare professions course, and I could collaborate with colleagues from there. Particularly, we did a lot in pharmacy, some nursing, some physiotherapy, but the pharmacists would have been my main collaborators, and indeed you have a pharmacist from Robert Gordon's with you now. So the world is very small. Today, this talk I'm giving is generic. I'm afraid that a lot of the pound signs and so on are indeed in UK pounds or US dollars, but we'll give you some guidance. It's difficult to put things into different currencies. So talking about cost and value in health professions education. And this is quite a topical area. If you had looked at the journals 5, 6 years ago, there would have been nothing on cost and value in medical education or health, nursing education, pharmacy education. It was something that people didn't seem to look at. But it's becoming more topical in recent years, and indeed there's a recent AME guide on cost and value in health professions education, and a second guide that's currently in production. I'm a co-author in those guides. And there's a Society for Cost and Value in Health Professions Education that's international. So there's increasing interest, probably because resources are, if they're not tight, you're lucky. But for many contexts, money is tight, resources tight. But even where that's not such a big issue, people are still looking to see how can we deliver education effectively for the least amount of money. There's no point in wasting money if we don't need to. So I'm going to talk about why we should consider cost and value, because it isn't just about the saving of money. We also, that's the cost side, but we also need to think about the value side. And sometimes more expensive is better. I mean, I personally, as a woman, I would say that's always the case when it comes to pairs of shoes, but this is about education. I'm also going to talk about things to do with the kind of tools that you can use to measure cost and value. So thinking about educational evidence, there's lots of journals publishing how we can do things, how we can best use simulation, how we should best do assessment, the ideal curricular design, you name it, it's there in the journals. There's a lot of evidence. I mean, most healthcare education journals have been going now for quite some time. The journal Medical Education has celebrated its 50th anniversary. Other journals are also well established. There is a lot of evidence out there, but the evidence doesn't always translate to practice. And it does sometimes, but it doesn't translate automatically. And one of the reasons for that is because what we do is informed by practical issues. So the decisions we take, the decision medical schools take and schools of pharmacy take, and those who are leading programs and leading universities take, are not just based on evidence. That it would be naive to think that that's the case. They're also based on practical issues, and cost is one such practical issue. Do we have the resources to change? Do we have the resources to do things in different ways? And money is a resource. So we need cost evidence if we're going to change practice. Yes, we need the education evidence. What is best? Is this way of assessing a skill better than another way of assessing a skill? But we also need to provide that evidence, that kind of practical side of the evidence, as well as the educational evidence, because we need both to inform decision making and to think of the consequences of different decisions. And we'll talk about that more as we go along. Here's one of the studies that we often refer to in giving this kind of talk, looking at how to teach and how to teach effectively. So this is a comparison of self-guided training, so dyad, peer-supported training versus instructor-led training. And it looked at the cost effectiveness. It's pediatric basic life support skills. So when it was dyads, when it was peers, self-guided training, just over 30% of those taking part met the competency criteria. When it was the instructor-led team, it was nearly 60% who met the competencies. Big difference. But then if you look at the costs, there's also a big difference in the costs. When it's peer, it's about $43 per participant. When it's instructor-led, it's instantly nearly twice as much, because teachers cost money. Okay? So if you were making a decision purely on the basis of cost, you would go for the self-guided training. It's obvious, it's cheaper. However, you need to think about more than that. So if we look here again, it's the same data, it's the same study. If you look at $10,000 US, so just for the purposes of discussion, if we had $10,000 US, that would allow us to train 233 students using the self-guided training. Only 109 if it's instructor-led. But actually, if you look, the number of competent individuals for the same amount of money is not so different. So yes, you can train more for less money, but we're not getting more through the competence threshold, or we're not getting many more through the competence threshold. So the question is, your policy decision is, are you training for quantity or are you training for quality? And that kind of information is necessary for the decision making. Okay, we need to know the cost, we need to know the educational outcome, and then we have to make our decisions about what our policy is on this particular case. So there's lots of questions that cost and value can help us address. And I'm going to go through some of the different types of things that you can do that you may wish to do locally as well. So are you interested in comparing benefits and effects? Well, actually, typically the first thing that people want to do is find out how much something costs. So we're not actually comparing anything, we're just adding up the figures, and that's the cost analysis on the right-hand side of the screen. So I'm going to give you an example study we did a few years ago, and it was an assessment. And Case van der Vluten's utility equation, which is relevant to assessment, is that the utility of an assessment is its reliability times its validity times its educational impact times its cost times its acceptability. Quite a long equation. And again, if you look in the literature, you'll see hundreds of articles looking at the reliability and validity of examinations, assessments, OSCEs, workplace-based assessment, you name it. Lots and lots of studies on reliability and validity. You'll also see fewer, but still quite a lot of studies in their educational impact, and some, particularly in the early days of assessments being new, the acceptability to learners. So, for example, when the OSCE was first brought in many decades ago, how did students, what did students think of it? Did they look upon it favourably? What did other key stakeholders think? Far fewer studies of cost. In fact, I think the one I'm going to report was the first one. So this was a study carried out in Aberdeen, led by my colleague Craig Brown. And Craig at the time was organising the final year OSCE, so this was absolutely his idea. He had looked at the research, he wanted to know how much it cost. And he looked and he said, well, there's not really a lot of research, and what is out there isn't terribly good. So let's see if we can add up how much our OSCE cost. And it was the finals OSCE, so it was high stakes, it was long. It was over 2 days, it had 15 stations, and it was for 185 students. That's how large the cohort was. And we had to get this assessment had to be right, it was valid, it was reliable, it was all those other things, but nobody had actually looked at the cost. So we started counting things up and categorising things. So, for example, we had 14 stations that required an examiner. I can't actually remember what the 15th station was, but there wasn't an examiner in it. We had 3 external examiners present. 12 of the 15 stations had paid actors or unpaid simulated patients. And even where the simulation patients were unpaid, they still had to get their travel costs, they still had to have their lunch and so on. We had consumables, marking sheets, equipment, anything that you need to run an exam. There was a lot of administrative time. If you think of skills assessments in your own context, I mean, these are burdensome. They take a lot of time to organise, and a lot of people are involved, the technicians, the administrators. We needed the venue, we needed to feed people in water, provide water and so on and so forth. And if you actually start listing all the things that happen, it's kind of an endless list. We also wanted to look at the hidden costs. So not just the costs on the day, but the costs leading up to the day, the necessary things that we needed to do. So we had to write the questions. We had to, that took a lot of meetings, a lot of time. Then we had to print produce everything that we needed for the assessment and test out questions. We needed to train our actors and our simulated patients, and we had mandatory examiner training. We also checked the data, we had examination board meetings and so on and so forth, particularly afterwards. So it's a big production, and OSCE is a big production. If you think of it as like a theatre production. So we literally counted up how much we were spending. I'm not going to go through everything in detail, but let me just pick a couple out for examples. So, you know, one, the examiner online training. Every examiner was giving up an hour of their time to do the online training. And that we estimated came out about £6,495 because our examiners were typically senior consultants, so their time is expensive. Now, we didn't pay our examiners for this. They do this through goodwill. But what we were trying to do is an exercise where if we had to pay, how much would things cost? The catering, for example, 2 days of catering expenses, examiners, dinner, food for the volunteer patients and simulated patients. It's actually not as much as I would have thought at £2,273, but you get the point. Everything has a cost. So we calculated the cost of the final year OSCE, the direct costs, at just over £65,000. But then when we put in the hidden costs, the external examiner time, you know, the fact that we needed to have things in place that we could then draw on for the exam, like we needed to have a simulated patient programme and we needed to draw on that programme for the exam. But if we took all those hidden costs into account, it came to nearly £90,000. And that's for one OSCE. Okay, it's a 2-day OSCE, it's a high stakes OSCE, but we were running OSCEs in every year and we were running formative OSCEs. So if you actually just extrapolate across all the OSCEs, all the skills-based assessments that you do, you can see that it's an enormous amount of money. But it wasn't really money that anybody was talking about. And after we did this study, one of the policy decisions was to try to look if we could cut down the OSCE so it took place over 1 day rather than 2 days, thus saving us a lot of time and money. And although I'm not presenting it here, we had a member of staff then went to do his master's looking at sequential OSCEs. So a sequential OSCE is where you give fewer OSCE stations almost as a test of competence. And then for those that fail, then there is a second OSCE day. But most people pass, so your second OSCE day might just be for 10 students, rather than the second OSCE day being for all 185. So Graham's thesis was taking exam data from previous years, working with a statistician to model and decide how many stations we could use in the first day OSCE as the screening test, and then that changed practice. So now at Aberdeen, the final year OSCE is over 1 day, and there's a second OSCE for those who fail more than a certain number of stations in the first day, thus saving money. Okay, so what about other questions? Do you want to know about benefits and effects? So the left-hand side of the screen, are you wanting to see what's good, what's less good, and then make your decision about, you know, keeping one of 2 options? So this is a study that we did, I was co-supervising a student at Maastricht University, and her thesis looked at selection. And we were really interested again in cost and value, but the really interesting thing in the Netherlands at that point is they had 2 systems in parallel. So we had a natural quasi-experiment where we could compare different systems, and that, you know, the opportunity to do that was just, it was too good to miss. So we wanted to look at the relative effectiveness of different approaches to selection. So as I'm sure you know, in medical school in the Netherlands, if your grade point average from school is high enough, you're automatically offered a place at medical school. So that's one way of being selected into medical school. You did very well in your exams. Golden ticket, admit 1. But then in parallel was the system of bespoke selection, which was kind of, I suppose, more of what one thinks of as contemporary selection in medical schools now. So it was blueprinted to outcomes, to CanMeds. There was a number of activities and 2 stages. So the first stage was a portfolio, setting out not just your exam results, but, you know, what else did you do to prepare for going into medicine? Why did you want to go to Maastricht? Why did you want to do PBL? And applicants were ranked. And then the second stage was an interview and a situational judgment test. So pretty intense in terms of time, and you know, time heavy. So we wanted to look at whether it was worth it. And this is very political, because in the Netherlands, in fact, these studies have been in the Netherlands press quite a lot. In Sana, the student has been interviewed, because there is a big debate about, do we do bespoke selection or do we do lottery? And it's quite a political debate. But we wanted to find out the evidence. So we looked at the costs and benefits. So with the, what could we save? What were the costs? So, I mean, savings would be, do we select better students through using the bespoke selection than are selected through the lottery? And what are the measurements of better students? Well, they're more likely to stay in medicine, they're less likely to repeat a block, they're less likely to have a reset. You know, those are the kind of things that we could say was better, and things that we could save on as well. I mean, they represented cost savings. And then we wanted to look at the costs of the selection process as well. And that involved things like the development time for designing the process, the administrative costs of communicating with students, setting up the visits for the interviews, and so on and so forth, and assessor time. So we then looked at the costs, and it's possibly worth saying that these things are quite difficult. It's quite difficult to collect the data, but we managed it. And overall, I mean, the lottery doesn't cost medical schools anything. That's all done at a different level. But when it was the bespoke system, there were high costs, as I've said. But then we looked at the students across those 3 cohorts. And if we looked in terms of dropout, repeating blocks, and resets, as I mentioned earlier, we reckon that extrapolating up, so it was the same size of group, we were saying that the gain of selection was about €200,000. So the costs of the bespoke selection process we estimated was €133,000. The benefits in terms of better student performance was just over €200,000. So our gain was €68,000. So that's quite a lot of money, you know. And we also showed that our actively selecting students got us better students than students that went through the lottery only, when their selection was purely based on grade point average. So, but this was in the preclinical years, so we also wanted to look at the clinical years. Slightly trickier to assess in many ways, but we had to look at workplace-based assessments and assessment of student performance on the CAN-MED roles during these rotations, and an annual progress tests. I'm not going to give you detail, because everybody's got different systems, but similar systems. Once students are in clinical placements, there are ways of assessing their performance and their progression. So we found that the selected students significantly outperformed the lottery admitted students each year. And interestingly, the differences between groups increased over time. So in their first year of clinical, there was a difference, there was a significant difference, but that gap widened. So those who had been actively selected got better, or the gap between them and their lottery selected peers widened by the end of the 6-year programme. And the differences were apparent in all sorts of different aspects of assessment. So we concluded through this series of studies that both groups performed well. It wasn't that the students that were selected through lottery were terrible students. They just weren't quite so good as those that went through the active selection system in terms of performance. And we concluded that if we wanted to select the best doctors, then a relatively costly active selection process was valuable. So let's also think about the next set of questions. What's meaningful? As I said earlier, it's not just about cost, it's also about value. So is there equivalence within some sort of meaningful measure? If so, we want to look at cost minimization. So I'm just going to give you a quick example of this. This was a study we did a number of years ago. In fact, it followed on from another study. So we'd published a study where we'd given students individual feedback on a simulation performance. So it was a simulated ward round. It was a staff-heavy, resource-heavy simulation. And every student who went through the simulation got individualised feedback. So that was a lot of cost in terms of staff time. They had to prepare the feedback, and then they had the time with the student to deliver the feedback. So it's resource-heavy. It got very, very good feedback, but we just weren't sure it was sustainable, particularly as cohort size increased. So we thought, okay, what else could we do? We looked at the literature, we looked at the educational evidence and thought, well, we could give feedback in small groups instead of giving individual feedback. And there were some challenges to this. Everybody thinks that individual feedback is best. But what is best? How big a difference is there? So we looked at individual versus small group feedback. It was in different students, which is a flaw, but that's the only thing we could do. And we looked at student feedback and student OSCE performance later, because the simulation, part of the point of the simulation was to prepare them for OSCE assessment. We actually didn't find any difference. There was no significant differences in terms of how well the feedback was received by students and how well they did in their OSCEs. But we had halved our hidden costs of simulation by putting feedback into small groups rather than individual. We reckoned that I can't remember what the actual estimate was, but say it was £100,000. Our cost dropped to £50,000 just by saving time. And because there was no difference in outcomes, students seemed just as happy, they were just as good on their performance in their later OSCE. Well, it was a no-brainer. So now this is the feedback is given in small groups. But we needed to do a comparison, and we needed to look at relevant outcomes. We wanted to get, so now we can have the maximum educational value for a given spend. And this is one of my colleagues, Stephen Maloney. He really kind of drove the international collaboration looking at cost and value in health professions education that I referred to earlier, and he's based in Monash University in Australia. So what else can we look at? Can we look at willingness to pay, cost-benefit analysis? This is quite complicated, kind of health economics. So I'm just going to give you a little bit of a whistle-stop tour. We've done a lot of work in this area and published a series of studies, but I don't want to get bogged down in methodological detail. I'm just going to give you a flavour of what I mean. So there's a particular health economics tool called a discrete choice experiment, and they're used a lot in healthcare. And this is an example that's very general, but if you're coming to the end of your current post and you're looking for your next job, there's 2 posts on offer. There's one that you've been offered, there's one that's being advertised, and you have to kind of look and balance up what you want in a job. So for job A, your monthly salary is basic, but it's in a city. Oh, it's going to be busy, your workload is high. You get your housing, that's good, but you don't actually get any professional development, any paid professional development until you've been in post 5 years. So you can see there's some pros and cons to this job. Now, job B, well, you get more money, that's nice, but it's rural, or you will be based rurally, that might not be so attractive. You won't be as busy, maybe that's attractive. Oh, but you don't get a house, but you do get training after just 2 years. So typically with discrete choice experiments, you get a combination of questions where these attributes of salary, location, workload, and so on are all mixed up, and you have to decide which is best. So we did something very similar to ask medical students about their career decision making. And at the time, there was lots of discussion in the literature about location being the most important driver. And we looked at trainees, so residents, and we asked them what was most important. And it wasn't actually location, it was working conditions, opportunities for their partner or spouse, and then location. So this was really useful for governments and policymakers. So a very whistle-stop tour through discrete choice experiments, because if I was going to give you detail, I could be here for an hour, but just to give you an idea of what it's about. So to come to near the conclusion of this part of the talk, health professions education is not cheap. We have finite resources and we need to make choices between different alternatives. And to navigate the alternatives and the options and informed decision making, we need good quality evidence of the cost variety as well as the education variety. So if this kind of study interests you, if this kind of thing interests you, these are the kind of things that we advise people to do in a cost-benefit type study. What's the context? What are all the costs? Appropriate analysis, consider comparisons, and link data with theory. So again, a bit of a whistle-stop tour, but just these are the things that are important because your context is different from my context, and you know, everywhere, no one university or country or system is the same. So thank you, and we'll pause at this point in time to take questions in that part of the talk.
Yes, thank you, Dr. Jennifer. Thank you. So I have a question here in relation to the fact that what you are talking about basically is cost economic evaluations done at the level of institution. But won't you need to go beyond this to a governmental level as well at some point? Because I mean, if you think about it, you can say this program is more cost beneficial than the other program at the level of institution. But what's the point if the sponsoring body or the government, Ministry of Health, if we're talking about public university, believes that sending students, for example, overseas to sponsoring students to study overseas is more cost beneficial than spending money locally? So wouldn't you need to look at the level of institution as secondary to similar evaluations at the level of government?
Well, yes. I mean, your example there of sending students overseas to train versus training them in country, is that the comparison?
Well, I'm saying that for a government, maybe it's not cost effective to spend so much locally. So what's the point of these local evaluations at the level of institutions that says one is better than the other if the problem is at the sponsoring body, the ministry?
Okay, well, yeah, but the sponsoring body also can do a cost-benefit analysis. So, for example, let's say a country sends 50% of its students overseas to train as doctors and trains 50% in country, just for the sake of discussion. So, of the 50% that go overseas, how many come back? Are they lost to the country? Are they lost to the country for many of their working years? You know, that would then actually represent a loss. That would be an effective policy decision, because there's a lot of evidence that if people go overseas, they don't come back. And if the government is supporting that, then they're kind of shooting themselves in their own foot.
Okay. So thank you very much.
It's what are the benefits in terms of contribution to the workforce? That would be what one would look at that level.
So basically, to recap, it's not only at the institution level, but studies have to go beyond this at national level, maybe.
Yes, you can go to national level quite easily. Yeah.
I have another question here, which is in relation to interpretation of this cost data. I mean, in health economics, we know exactly that we have a willingness to pay threshold, based on which, you know, a drug is too much to pay for or not. I don't assume you have this in public in health education, right? I mean, how can you determine whether $2 per an hour of teaching versus something else is a lot of money or not?
Yeah, typically there are no rules and regulations in the way that you described for pharma. We have talked about how nice it would be if we had the equivalent of a QALY for education. So what is there a measure that we can use globally that everybody would understand and would be meaningful globally? And there isn't that at the moment, but you know, give it time, give it a couple of decades, and maybe we'll find something like that.
Okay, thank you. Which takes me to another point, the generalizability of results. I mean, are these cost benefit results or cost effectiveness results for a program generalizable to the same program in different settings? I would assume no, because of so many variables I can think of. But does it make sense to redo the same evaluation and again for the same program in every different setting? I mean, again, in this type of evaluation in pharma, we do sensitivity analysis and things. So how are you handling it?
Yeah, sensitivity and specificity. I mean, I think that you have to extrapolate. So, for example, I was talking about the OSCE, the 2-day OSCE. Now, of course, the costs to, say, you in Qatar would be not the same as they are in terms of pounds and pence. But you could look at a study and think, gosh, well, yes, now if we look at our OSCE, the chances are that it will be expensive because we have the same facility. You know, we have X number of OSCE stations, we use simulated patients, of course, we have examiners, we give people lunch. So actually, the chances are that it's quite an expensive exercise. I wouldn't necessarily repeat the study. You could just extrapolate the generalizability or the transferability. You may want to do a local study for local purposes, but I think that you can take some of the educational evidence and think, okay, is this relevant to my context? What parallels, what similarities do we have? And to make a judgment.
Thank you. I have another question. Maybe we'll take another two before you go on. What are your thoughts about the online learning cost and its outcomes in this COVID era, and how it will change the way we function in health education?
Okay, I'm not going to answer that question because I think that preempts the whole next part of the talk, and that will be something that we'll come to in due course.
Okay, so maybe a last question. What do you think are the main research priorities for health professional education, and are these priorities likely to be the same across professions and the world?
Well, that's a very good question, because you know, different professional groups have different priorities. But I think there's probably the commonalities are that we all want to graduate competent healthcare professionals. So we're going to be thinking about, are our students reaching their competencies? Are we training them effectively? Are we assessing them effectively? Are our workplace-based assessments effective? Do they weed out the weak students? So I think that if we actually put people from all different courses, nursing, pharmacy, medicine, you name it, physiotherapy in a room, those running the programs, I think we can probably get a list of core things that everybody is interested in, and then compare across programs at those core, I mean, not variables, but core factors.
Excellent, Dr. Jennifer. I think this is it for this part of the session. You may want to go on with the second part.
Okay, thank you. Let me just go back to my slides. Can everyone's obviously seeing the slides? I do hope so.
No, we don't. We don't.
Okay, right. Let me just go back. I don't have the share. Great, thank you. Okay, everyone. So this second, good. So this second part of the presentation is just considering COVID-19, reflecting on COVID-19, which I guess we've all been doing now for quite some months. So, educationally, speaking from my own experience, I've just felt that we were running to keep up with events. Every day something changed. We didn't actually know particularly what was happening. Our government was putting out warning alerts. We were endorsed on orange, so orange alert, then red alert, but things were changing all the time. So anything that we did initially, we were just having to be pragmatic. I suspect that this chimes with your own experience. People didn't have much notice. You were kind of watching the rest of the world. I mean, Singapore got COVID early because of Chinese New Year. There was lots of travel. So it was really, I mean, I think the 7th of February was the first time we started talking about what we were going to do. But then we shut our medical school at the beginning of April, and we had to stop a lot of activities between February and April. But we were running to keep up. We just didn't really know what was happening. So we had to be pragmatic, and thank God for technology, because we had a really good digital learning team, really good IT team, and without them, it would have all just crashed. So what we have reflected on is that often people will talk about, let's move some of our learning online. And there's lots of discussion in the literature about how much effort it takes to move things online. So these are a couple of older studies, but I used older studies on purpose because these are long before we'd ever heard of COVID. And these studies were estimating that you needed 34 hours of time, of instructor time, to develop 1 hour of instructor-led online training. You needed 33 hours to put 1 hour of PowerPoint onto e-learning. You needed 750 hours to get 1 hour of simulation online. That's the last example. But how come then we managed to get everything online with COVID with a lot less time? And I think that, you know, technology has improved. We're all more familiar with using technology, but we just had to get on with it. But it was crisis mode. It was dealing with things as they came up, thinking, what can we do? What can we do to ensure that the students get learning experiences of some sort? And I think it was only when things started, I wouldn't say calm down a little, but we were able to draw breath at the end of the normal academic year. And that the second half of the academic year hadn't been normal at all. But there is always a little bit of downtime in the summer where we were trying to think, okay, what have we done and what should we keep, what seemed to work, what seemed to not work? But of course, all the time thinking, when will this end? Will it end? What can we do? The uncertainty has been challenging. So all the journals have been publishing things on medical education and health professions education during COVID. But I particularly like this quote, that the efforts that we made during COVID, many of those efforts will demonstrate the areas in which our education systems require greater resilience. They will also offer new insights into what practices we hold precious simply because we've never had the motivation to try something different. But also, what have we lost when we were forced to do so? So this quote covers that. There are things that we do that are perhaps could be done better, and there's things that we do just because we've always done them. And there's things that we did during COVID which will have worked and probably should stay, but there are things that maybe have not been so beneficial or should not be kept in the longer run. So I'm sure, just like most universities, you did a big shift to simulation. You'd have done a big shift to online learning. You would have done a big shift to social distancing where you were allowed students coming into environments. So I mean, when we reinstated face-to-face teaching, laboratory teaching, we have to do smaller classes so that students can be socially distanced, which means that we have to run the same classes multiple times because we can't have all the students in the room at the same time. So that's a real burden for staff, but actually I'm very glad that we did it, because for the students who had no face-to-face teaching for many, many months and very little face-to-face contact with anyone other than their immediate families, they are so pleased to be back in the labs. They're so pleased to be at anything that's face-to-face. It's only limited, but you can see it's very welcome to them. Medical teacher did a special edition. What I see is actually a lot of things have worked really well, moving assessments online, moving admissions online. But our students haven't been getting the clinical contact that they would normally have. And I do worry that we're kind of losing sight of what health professions education is about. It's not all about simulation. It's not all about online learning and webinars and so on and so forth. It's about patients and people. And that's something we need to reflect on. But this is a table that we put in a paper that I wrote with my colleague Martin Tolsgaard and Rachel Ellaway. Sorry. With everything that we've done because of COVID, we need to look at it critically. You know, what do we must we resume, no matter what, no matter how difficult it is? Is it patient contact? Is it clinical rotations? What is it that is absolutely the core of healthcare education that we need to find a way of bringing back. On the flip side, what have we done that actually is really good and we want to keep because it works really well and it supplements other learning and it's well received by the students and it seems to help them fulfill their competencies and help them with their learning? What do we do? This is going back to Kevin's point about what do we do that's just habit or tradition? Now, what can we change going forward? What can we just drop? Because actually, we were only doing it because nobody had thought about changing it. And what have you learned in terms of what needs to be added? And also, do we need to prepare for this to happen again? I'm slightly cynical about, well, not cynical, it's very nice to have news about a vaccine for COVID-19, but what happens when it's COVID-20 or COVID-21? Will this all happen again? How resilient do we need to be in terms of our educational systems? Is this all going to disappear in a few months and never happen again, or not? So my own view is that it's about healthcare professions education is all about patients. And we can teach our students lots through simulation. We can teach them lots of knowledge through online learning. There's a lot we can do. Great scaffolding, but they need to have patient contact. Okay, some of that can be done virtually. I mean, working in Scotland, we did a lot of telemedicine for a long time because people were in remote and rural areas, they were in the Highlands, they were in the islands. So there was a lot of effective telemedicine because of distance, but maybe we have effective telemedicine because of COVID. We need to train our students to see patients remotely, but we also need to remember that they need to see patients in person as well. And it is about the person, not just the knowledge and the skills or being able to do an OSCE or being able to pass an exam. It's about being able to interface with a patient, and it's also being able to interface with colleagues and work in a team. And how do we do that during COVID? How have we done that during COVID? And that kind of social and relational aspect of healthcare, I think, is the thing that's most in jeopardy at the moment. We may be graduating people who, tick the boxes, but if this goes on for years, will they know what to do with a patient or a team? So I'm afraid I have no answers. I just wanted to put some thoughts out there for us to muse over and discuss.
Thank you very much, again, Dr. Jennifer. And I have a couple of questions. The first one is basically, what are, based on expertise and readings, what are the main gaps that has been observed in our health professional education systems so far, gaps that we did not know existed until now in the era of COVID?
In our systems?
Health profession education system, generally speaking, gaps in how do we do things internationally that we thought are okay until now.
Yeah, that is interesting. What are the gaps? I think maybe there's been too much of a move towards things like simulation. And it's not even the move towards simulation, it's the emphasis on high fidelity simulation, I think, is one of the issues. Because you can simulate perfectly effectively with a banana skin for suturing rather than some expensive piece of kit. I think what we maybe lost was some innovation previously, and that's something that maybe COVID has brought us back to thinking, how can we do something? How can we do it easily, cheaply, quickly? And it's made people think about what's absolutely core to health professions education, as well as how can we do something when our conditions are very different and very limited. Okay,
thank you. I have a question. Seeing you talked about selection, I was just wondering about, moving to online selection, students for admission. Did you observe any impact of this on the number of people admitted? Did it go up or down? Or the quality of students in their initial years? The fact that students cannot go into face-to-face interviews as before. So how did this affect the admission, generally speaking?
It's a good question. So the timing of admissions my particular medical school meant that we couldn't run our multiple mini interviews. So normally our students, that we select initially in grade point average, then they do an admissions test, they do the BMAT, but there's many different admissions tests around the world. Most of those can be sat online. So we had the grade point average, we had the BMAT results because the BMAT window had closed. But the next stage would have to have selected X number of students to come in for a face-to-face multiple mini interview in MMI. We couldn't do that, but what we did was we transferred our MMIs online and did them remotely. So the students were sitting at home and we rotated them through the MMI stations. We cut down the number of stations. There was things that we couldn't do, but we basically had a virtual MMI and we reported it in the literature actually. And that worked well. In many ways, technologically, it was a lot of work to arrange, but we did it. But of course, for the students, they didn't get the chance to come in and see us and meet us and see the medical school, because I think that in a lot of admissions processes, part of it is it's the kind of the relational, the social. Applicants and their parents come, they visit the halls of residence, they visit the campus, they meet other students, they meet staff. We put it on as an event. So it's not just about the score in the MMI, it's also that kind of finding out more about the institution. And Singapore is small, so it probably wasn't so important for us. But I'm thinking like in the UK, medical students will apply to 4 different universities. And they will go and visit all of those to decide which one they want to go to, if they get an offer. But it's like, do I want to live here? Do the people seem nice? Do any students, are they enthusiastic? So that social side was lost, but there was nothing we could do about it. And we offered the same number of places and our numbers are capped. We have no option. We got the same, we got the right numbers, but of course we don't know what the students will be like. We won't know that for a few years. Nobody will.
Okay, yeah, fair enough. Thank you. So I have last 3 questions, maybe relevant ones. So we talked about changes in programs and a level of colleges. What about changes at the level of accreditation bodies to accommodate for what's happening?
Accreditation.
Yeah, regulatory and accreditation changes to match what's happening in real life, basically at institutions.
Yes, I mean what's tended to happen is the accreditation bodies have waived their normal criteria. That's happened across the world, so that medical students could graduate and move and transition into postgraduate. I think it was eminently practical. What else could they do? I suspect that it may be that the cohorts who graduated this year may need a little bit more support in the first couple of years postgraduate, because they didn't necessarily have, they didn't have the full clinical exposure, they didn't have the full training. And systems will have to adjust accordingly. So a bit more support. There might be gaps in knowledge, and those gaps in knowledge are going to be different for different programs for different schools, because everyone's got slightly different curriculum. So for example, our students missed some competencies, but if we went back to Aberdeen, the curriculum in the final year is different. Their students will have different gaps. So every individual training program is going to have to kind of say, well, this is what they missed, and these are things that we're going to have to look out for at postgraduate level. So there's going to have to be a lot of communication and discussion across traditional boundaries. So rather than just the School of Pharmacy or the School of Medicine doing their thing, graduating the students, and then there's somebody else's problem, I think we need to have much more coordination across the different bodies and institutions.
Thank you. I have another question from Derek, your older colleague, Dr. Derek.
He's not that old.
No, you're older.
Former colleague, yeah.
Former colleague. So the question is, pre-COVID QU, in pre-COVID, QU Qatar University had very little online, and Dr. Derek has a concern that there will be an expectation to drop this as soon as possible. How do we convince the university that we can return some online delivery in a blended approach that that quality may improve?
Oh, that's a really good question, and it's evidence. So you need to look at the student outcomes and the student feedback. We shifted our team-based learning from face-to-face to online during COVID. It's still online. Normally we would have 150 students in the learning studio at the same time. We can't do that. So that remains online, but we were able to compare the students who had their learning purely face-to-face pre-COVID with those that had a lot of their learning shifted online during COVID, and we looked then at end-of-year assessments. So of course we were comparing different cohorts, but we could adjust for that statistically. And we actually found that the ones who had had their learning shifted online did better in their end-of-term exam. So evidence like that helps us say, well, actually it's okay to keep this online because actually it seems to work. But there are other things that may not be the case for. So I think it's about evidence, it's about evaluation, quality assurance. Look to see what the relevant outcomes are, look at student feedback, and then that will help in terms of making a case to keep things.
Okay. So another question. Yeah, so is 1 year sufficient to make decisions about such long-term changes? I mean, in the questions, in the table you had with questions in it, you were talking about removing things entirely or not. So just 1 year of observation of performance of students under such sudden changes in relation to how things are for both students and faculty members. Do you think you have enough information available to make such big decisions? I mean, you know, students it may take years. If I can add to this, it may take students years to, for example, learn how to handle stress in an exam room. So, but now putting all these students in this, environment where they have to do everything for the first time. So, do you think is 1 year of COVID sufficient for you to make such changes?
No, I mean, it's interesting because COVID, I mean, it's been a very peculiar time. It still remains a very peculiar time with a lot of stress for students and staff. I think that it does come down to educational judgment, just as you have clinical judgment and clinical reasoning. We have to use our educational judgment. So we're not going to completely change the face of healthcare education because of one pandemic, but maybe we can say, actually, I think that could go, that one thing in the year 2 curriculum can go without, and we can be quite confident that it's not going to make a difference if we lose it. But it's not about changing how everything looks. It's about the kind of using judgment to think, okay, actually this new thing seems better than what we were doing before, so let's drop what we did before. But it's not about large scale change.
Okay, thank you. Maybe the last question, and it's part of a question I have. Do you think underdeveloped world can cope with the complication in the context of what you're talking about, relying so much on technology and so on?
Yeah, now that's very interesting because we did an AME webinar on this in March, I think, and we had something like 700 people online and another 500 accessed it later. And a lot of the questions from lower middle income, LMIC countries was about the technology. They just didn't have the resources, and also the students didn't have the resources to log on. They didn't have reliable Wi-Fi. They didn't have reliable technology, and I think it is a big issue. And there is the potential for the gap between richer countries and less well-off countries to widen because we are so dependent on technology currently. Okay, excellent. Thank you very much. And with this, Dr. Jennifer, thank you so much for joining us and for sharing such important and timely information, whether in relation to cost or teaching during COVID. Having you was really a pleasure. And we'll have to pass the mic now to my colleague, Dr. Gerhard, for the next session. Thank you again, Dr. Jennifer.
Thank you.
Thank you. And thank you for moderating so well. Thank you, everyone.
Great.
Thanks.
So hello everyone, my name is Gerhild Sauner-Kudelka. So I'm going to moderate the morning session. Again, thank you, Dr. Jennifer. It was an excellent presentation. So we will have the first 4 short presentations in mixed kind of topics. And the first presentation we will have from Dr. Mohamed El Reyes. He will talk about a cardiovascular kind of theme, and the presentation title is Are Elite Endurance Athletes at Higher Risk of Cardiovascular Disease, a Genetic and Metabolic Approach? So Dr. Mohamed, we are very much looking forward to your presentation. We will hand over the microphone to you, and please put up your slides and start. Thank you very much.
Thank you very much, Dr. Gerald, for your kind introduction. I still don't have the mic. If they can hand it over, please. The share option, please.
We hear you very well. It's perfect.
The share option is not there.
Mr. Shushar, could you please hand over the...
Yes, Mohammed, you're there now.
Okay, great, I got it. Okay, thank you very much for having me today. I'd like to thank the organizing committee for giving me the opportunity to present to you our intriguing research question: Are elite endurance athletes at higher risk of cardiovascular disease, a genetics and metabolomics approach? Before I start, I would like to introduce elite athletes. Elite athletes are professional athletes who participated in national or international sports events. They're broadly classified into 2 categories, depending on the kind and intensity of their exercise. The dynamic, also known as the endurance sports, and the static, known as the power sports. So the dynamic or endurance sports, they represent changes in muscle length due to regular contractions producing a limited but long-lasting intramuscular power, whereas the static or power sports, they represent a greater intramuscular power with little changes in the muscle length. Now, each one of these categories is subdivided into 2 categories, moderate and high. So for endurance sports, based on the maximal oxygen uptake percentage, or V2 max, that is achieved with maximum cardiac output, they're divided into moderate, less than 70% V2 max, and high, greater than 70% V2 max. Similarly, with the static or power sports, based on their maximal voluntary contraction percentage gained with increasing blood pressure, they're divided into moderate, less than 50% MVC, and high, greater than 50% MVC. Of course, some sports require both power and endurance. Now, the increasing dynamic component here is results in a greater cardiac output. So we're talking about a larger stroke volume, whereas the increasing static component results in an elevated blood pressure. So together, the stroke volume and the blood pressure constitute what is known as the cardiovascular demand. Accordingly, sports have been classified into 5 categories, depending on the cardiovascular demand: low cardiovascular demand, low, intermediate, medium high, and high. Now, the higher cardiovascular demand, the more electrical, structural, and functional myocardial adaptations, and the more constraints in the cardiovascular function over time. This has led to what is known as the exercise paradox. And hence, we ask the question, are elite endurance athletes at high risk of cardiovascular disease? As you all know, exercise is good for you. It reduces your all-cause mortality, reduces your cardiovascular risk, hypertension risk, type 2 diabetes risk. However, the high volume exercise causes increased risk of cardiovascular disease, such as atrial fibrillation, coronary artery disease, myocardial infarction, increasing your sudden cardiac death risk by 2-fold at least. So accordingly, we hypothesize that there is some metabolic and genetic biomarkers of increased cardiovascular risk in the elite athletes. So our study rationale was that some evidence suggesting increased cardiovascular risk in elite athletes remains controversial, since evidence detection of the markers of increased risk at the metabolic and genetic levels would provide clues for potential mechanisms underlying the increased risk of cardiovascular disease. So our aims were to investigate the presence of metabolites associated with increased risk of cardiovascular disease in elite athletes who belong to high cardiovascular demand group. And the second aim is to investigate whether there is an evidence of genetic predisposition to increased risk of cardiovascular disease in athletes who belong to high cardiovascular demand group. So our methods, basically, we collected samples from 1,260 elite athletes from the anti-doping labs in Qatar and Italy. And we carried out metabolomics on 700 samples at two different stages, discovery stage and replication stage. Similarly, we carried out genome-wide association study in the whole entire cohort and also at a discovery stage, and we replicated our data in two independent cohorts of elite athletes from Russia and from Japan. Now, having the metabolomics data and the genomics data, we carried out the mGWAS, or the metabolic GWAS, where basically we looked at metabolites that are genetically determined or genetically influenced. And this is basically a schematic, shows our cohorts. So you can see 1,260 in total. We combined the red and the orange groups. So this is the high cardiovascular demand and the medium high versus the yellow and the blue. So these are the medium low and low cardiovascular demands. So now moving to the first aim. In terms of metabolomics, we carried out on-target metabolomics, and we identified a very clear separation in the scatter plot from the orthogonal partial least square discriminant analysis. You can see a very clear separation between low cardiovascular demand athletes, represented here in green, versus the high cardiovascular demand athletes represented in blue. Now, looking at the loading plot, corresponding loading plot, we identify which metabolites are responsible for this separation between the two groups. So in the high cardiovascular demand group, you can see these golden or orange dots. These are the phosphatidylcholine. You can also see these pink dots. These are the phosphatidylethanol and you can see here valine, isoleucine, and leucine. So basically, these are the branched chain amino acids. They are all accumulating or enriched in the high cardiovascular demand group. On the other hand, in the low cardiovascular demand group, you can see in yellow, the fatty acid, monohydroxy fatty acid acylcarnitines, and in blue, the gamma-glutamine amino acids. So what does it all mean? If you look at the low cardiovascular demand group, you find accumulation of diacylglycerols containing the precursor of arachidonic acid, and you also find accumulation of eicosanoids, which are the products of arachidonic acid. Whereas in the high cardiovascular demand group, you see accumulation of diacylglycerols containing arachidonic acid that is known to be associated with increased risk of cardiovascular disease, as well as we see accumulation of branched chain amino acids, which are also known to be associated with increased risk of cardiovascular disease. So also looking at the high cardiovascular disease group, cardiovascular demand group, we find accumulation of phosphatidylcholine and phosphatidylethanol amines, both of which have been associated with increased risk of high blood pressure and cardiovascular disease. We also see in the same group accumulation of cortisol, the stress hormone, that is known to be also associated with increased risk of cardiovascular disease. So together, our data suggests the presence of metabolic signature of increased risk of cardiovascular disease in athletes with high cardiovascular demand. Moving to that second aim, doing the genetics or genomic studies. So this is the Manhattan plot, shows accumulation of SNPs at chromosome 11 with significant p-values. This is the QQ plot showing nice positive correlation between expected and observed associations. So this is part of the QC process. And finally, when we zoom into our top metabolite, this is the regional association plot. You find number of SNPs in linkage disequilibrium. So basically, this gives you more confidence in that the effect or the association you're seeing is actually genuine. And these are the top 2 SNPs. So this is our study, and this is replication in the Russian cohort and the Japanese cohort, and this is the combined p-value. So this p-value is the first genome-wide association study significant p-value between SNP and elite athletic performance. This is, nobody has before reported significant association at GWAS level of significance. And we reckon that we managed to be successful in this task where others were not as successful because of the large cohort that we collected, as well as our refined phenotype. So this the other polymorphism, same thing. This is our study, Russian cohort, Japanese cohort, and combined p-value meta-analysis shows also Bonferroni level of significance. Now, what are these 2 SNPs? The first SNP is located in myosin binding protein C, a gene that is known to be associated with cardiovascular disease. The actual gene has got function in cardiac contraction. This particular polymorphism has been shown to be associated with mild cardiac hypertrophy. So somehow it is giving these athletes the advantage of absorbing more oxygen. So when we actually tested the V2 max in carriers of this polymorphism, they actually had significantly greater V2 max compared to carriers of the other alleles. Similarly, the other polymorphism, it was associated with adrenal, it is located in a gene called NR1H3 that is, the function is adrenal steroidogenesis, and the associate phenotype basically has been shown to be associated with changes in lipid metabolism. Similarly, when we looked at the carriers of the T allele, we found that they have increased V2 max compared to carriers of the other alleles. So what does this mean? Our data suggests the presence of genetic predisposition to increased risk of cardiovascular disease in elite athletes with high cardiovascular demand. Now, moving to mGWAS, so now we try to zoom into metabolites that are CVD metabolites, the cardiovascular metabolites, and we try to find whether they are genetically influenced or genetically determined. And indeed, these polymorphisms, these metabolites, these are top metabolites identified in the high cardiovascular demand group. They are genetically determined, and the p-values are all significant. And interestingly, the genes, the corresponding genes, have been all 10 of them associated with increased risk of cardiovascular disease through different mechanisms. For example, through dysregulated steroid metabolism, through dilated cardiomyopathy, cardiac death, heart failure, coronary artery disease, ischemic stroke, homocysteine levels, blood pressure, etc. Now, I want to draw your attention to the top one, because this is the novel MQTL that we report for the first time. It was not identified before in non-elite athletes. Now, this is the regional association plot for this particular SNP. Again, you can see a number of significant SNPs in linkage disequilibrium, giving you more confidence in your analysis. And then you can see there is a genotype dose-dependent effect of this polymorphism. So the AA carriers have lower androstenediol, which is basically a product of DHEAS. And so the AA allele are associated with the lowest levels, and the low DHEAS levels have been shown to be associated with risk of cardiovascular disease. So again, our data suggests that CVD metabolites are determined by genetic predisposition in genes known to be associated with increased risk of cardiovascular disease. So what does this all mean? Now, putting it all together, our metabolomics data identified a number of metabolites that are associated with increased risk of cardiovascular disease through increased heart disease, blood pressure, stress cardiovascular risk, and steroid degeneration. Our GWAS data identified 2 genes, SNPs in 2 genes that are known to be associated with increased risk of cardiovascular disease. And our mGWAS data has identified a number of candidates that are previously reported to be associated with increased risk of cardiovascular disease. Together, we believe that all these signatures, metabolic and genetic signatures, are basically pushing the elite athletes under high cardiovascular demand into increased risk of cardiovascular disease and potential risk of sudden cardiac death. So the take-home message is, this is the first evidence of metabolic signature of increased risk of cardiovascular disease in elite athletes with potential genetic components. Future studies are warranted to further validate these findings for early diagnosis and potential intervention. These are some of our references that describe the work that I just presented. And I would like finally to thank my colleagues at the anti-doping labs in Qatar and Italy for providing the samples. Without these samples, this project would have not been possible. And also our colleagues at Hamad bin Khalifa University and Will Cornell Qatar for providing biostatistical and bioinformatics support. And finally, Qatar National Research Fund for generously funding this project. Thank you very much, and I will take your questions.
So thank you so much, Dr. Mohammed. It was a very interesting talk. Just to mention, because I'm sorry to say I forgot to mention it in the beginning. So Dr. Mohammed works as an assistant research professor and PI at BRC, so the Biomedical Research Center within QU. Thank you so much again for your talk. And if any of the attendees has a question, please put them in the chat. I don't see any question yet.
I could have one, Gerhild.
Okay, please, Dr. Egon, go ahead.
I'm a little bit puzzled about this. Recently, there was a study on dementia and football playing.
Mm-hmm.
You probably heard about it. It was everywhere. Mm-hmm. In that study, the cardiovascular disease was reduced to 70% among the elite football players, soccer players. How does that cope with your findings here?
Yes, so basically, that's an excellent question, Dr. Egan. The point is, we have actually identified a group of athletes with high cardiovascular demand. So these athletes have high stroke volume and high blood pressure. They belong to sports that kind of predispose you to these conventional cardiovascular risk factors. The football players actually belong to the moderate low cardiovascular demand group, not the high or moderate high cardiovascular demand group. So they are basically at lower risk, but I can't be sure until basically we study these samples for, in particular.
But that brings me back to the high, as I saw kayaking and canoeing were among the high. I'm kayaking, but I don't kayak the way they do because I'm doing like strolling and having fun and go to the beach and out and there. So this is very different. So it must be the elites who is really doing very short strainers like weightlifting and these things.
Yes, yes, correct. So basically, in that group, you will find elite athletes who have very high both power and endurance. So basically, they have a very large stroke volume as well as the high blood pressure. But of course, this does not apply to us. These are we're not under this kind of strenuous exercise like they do. Basically, I think in general, the general message is that exercise is definitely good for you. But in terms of why do we see the sudden cardiac death increased risk in athletes, in elite athletes, whereas it's supposed to be good for you? This is because they're actually pushing their systems too much, and because there is some kind of genetic predisposition, as our data has shown.
And coming back to that again, if you have hypertrophic cardiomyopathy, which was one of the genes, or one of the predispositions, it usually transmit into an overmortality of sudden cardiac death. The hypertension, the steroid would usually go more to the heart failure, maybe to the cardiovascular disease. Do you see any differences between the two ways of affecting the heart negatively, that there are different kinds of diseases in the two different genetic predispositions?
This is really an excellent question, Dr. Egan. I think what we need to do is basically start to stratify these athletes according to their sports and genotype, and try to see whether we are seeing just evidence of cardiac myopathy, hypertrophy, or they are more dilated cardiomyopathy, or what kind of real phenotype we are seeing. This is something that I'm really hoping to do in collaboration with Aspitar, and I hope that this will be the way forward.
Thank you so much, Dr. Mohammed. for answering the questions. Thanks, Egon, for the questions. And I just got 2 WhatsApp messages. You got 2 more questions, but unfortunately we are out of time. So Dr. Mohammed Riaz and Dr. Vijay, if you would like to maybe send in the chat your question to Dr. Mohammed El Reyes directly, I think that would be nice. Sorry that we can't have them now because we have to move on to the next session. Once again, thank you, Dr. Mohammed.
Great presentation. Thank you so much for having me. Thank you. It's a pleasure.
Thank you.
Thank you.
And we will now move on to the next talk. First, I would like to make an announcement. Mr. Suju, I don't know how to pronounce his name, from IT, Shuja, I think, just asked me whether it might be easier to get the attendants ask their questions directly. And I think so, yes, because constantly checking my WhatsApp, that doesn't really help. So after the next presentation, you can just unmute yourself and ask your question directly. So with the next presentation that we have will be in the cancer field, and we have Dr. Mohammed Fasihu Alam with us. He is an assistant professor at the College of Health Sciences, and he works in public health. And we are very much looking forward to hear his presentation. And the title will be erlotinib as a maintenance therapy for non-small cell lung cancer, use of Markov decision analytical cost effectiveness model. Sorry. So we have it. So Dr. Mohammed, please, the microphone will be handed over to you. We see your presentation already, and please start with your talk.
Okay, can you all hear me? Okay. Good morning, everybody. Thank you very much for having me in this presentation. Actually, I'm going to present about healthcare technology appraisal by a regulatory body, which is NICE, National Institute for Health and Care Excellence in the UK. And the healthcare technology we're talking about is medicine for non-small cell lung cancer patients as a maintenance therapy. And we know that healthcare technology could be medicine, diagnostic techniques, surgical procedures. But in this case, we are talking about a cancer drug. Okay, so the way I have organized my talk is like, I'll give you a small background of the study, and then we'll talk about the methods we have applied, and then we'll present some key findings from the study, and then I'll talk about some policy implications and concluding remarks.
Dr. Mohammed Alam, can you make a slide mode, please? Make it bigger. Slideshow. Thank you.
Okay. So the technology appraisal program by NICE. NICE is a regulatory authority, as I mentioned. What actually they do, they assess the manufacturer submissions, appraisal submissions independently. They send it to the independent review group, evidence review group across 12 academic institutes in the UK. And then the evidence review group, actually they assess, and then they have some critiques and recommendations, and based on those recommendations, NICE make the decisions on the appraisal document. So what generally we see in most of the cases, when in manufacturer submissions, the clinical and economic evidence for the technology, generally the clinical evidence comes from the clinical trial, and economic evidence comes from the decision analytical modeling, where the manufacturer, they want to see whether the treatment has got long-term benefit in terms of health implications and also resource implications. So that's what actually the evidence review group, they assess. And in most of the cases, they find some structural uncertainty in the cost effectiveness model, hence the motivation of this study. Actually, we wanted to see whether any structural uncertainty has got any impact on the reimbursement decision for this technology. So that's the main aim of this study. So the patients and the condition we are looking at here, the non-small cell lung cancer patients, we know that around 85% of the lung cancer actually accounts for non-small cell lung cancers. And non-small cell lung cancer are generally aggressive, and around 67% patients diagnosed as stage 3B and stage 4, are the non-small cell lung cancer patients. It is more common in older people, and it is less prevalence in the population under age 40. And most diagnosed cases are actually fatal, and 1 year and 5 year survival rate is around 30% and less than 10%. So it is really very, very aggressive disease. So what are the treatment options for these patients? Based on the NICE recommendations, NICE guidelines published in 2005, they are suggesting, chemotherapy, combination chemotherapy. The first line is platinum-based chemotherapy, and which is added by active steroid drugs. We know that platinum-based drugs are aggressive, and patients, need to be reasonably fit. So, excuse me, my slide. Sorry for disruption. Actually, my slide has been.
Okay, just a minute.
Mr. Shusha, sorry, I don't know what happened here.
I'm checking it right now. Go ahead again.
Sorry, Dr. Fazli.
That's okay.
Share your slide again, please.
Go ahead.
So can you hear me now?
Yes, we can hear you. Thank you.
Okay. Okay, so we are talking about the treatment option for this non-small cell lung cancer patients. As I said, the first line chemotherapy is platinum-based, and again, it is added by some active cytotoxic drugs. And platinum-based drugs are generally aggressive, and patients need to be reasonably fit. Those responded from first-line chemotherapy, actually, the current practice is, at the time when the manufacturer submitted, current practice was like, after 4 to 6 cycles of chemotherapy, patients say their condition are stable and there is no progression in the disease. And most of these patients who have responded from the first-line chemotherapy, they haven't gone for the second-line treatments. A very low percentage of patients go for second-line treatments, and in case of second-line treatment, there are a couple of drugs are recommended. So there is a need for first-line maintenance therapy for patients who have responded from the first-line chemotherapy, and for those disease has not progressed. So that's the main motivation of this manufacturer submissions. So they are suggesting that allogeneic can be used for this non-small cell lung cancer patients as a maintenance therapy, those responding from the first-line chemo. So that's the motivation, that's the indication. So manufacturers submitted their submission to the NICE, and their submission is based on, again, clinical evidence and cost-effectiveness evidence. The clinical evidence they used from the certain clinical trial where they had 3 groups of patients, ITT, for those stable diseases, and also non-ischemous histological group. So they consider 3 types of patients, 3 groups of patients. But for our study, we consider only ITT group. And the clinical evidence, again, is from the clinical trial, as we mentioned. But for economic evaluation, what we need to have long-term implication of the drug on patients' health outcome and resource implications. Hence, they need to have some sort of mechanism to predict or to project the long-term benefit beyond the trial period. So that was the main factor for manufacturers to consider a decision analytical model, cost effectiveness model. So in this case, what the evidence review group found, they have found some structural uncertainty in the cost effectiveness model, and the cost effectiveness model is the typical cost effectiveness model generally we see in the cancer patients, where we've got 3 stages of in the model, because we model disease progression from one state to another state. So in this case, progression-free, then progress, and then death. And the model they consider is not a true transition state transition model. So what they considered a projection model in order to predict the progression-free survival and overall survival beyond the trial period. So that was the main problem found the evidence review group with the manufacturer submission model. So what we did, we restructured the model. We considered a true transition, state transition Markov model, and then we have reanalyzed the model, and then we have found some differences in the results, and we wanted to see whether actually structural uncertainty can change the cost effectiveness decision for the policymaker. So that's the main objective of the study, because we know that long-term benefit can also be can only be captured by a long-term modeling of the health outcomes and long-term modeling of the health events beyond the trial period. So in this case, what we did, we used Kaplan-Meier summary survival data from the manufacturer's published document, which the only thing we had. So in this case, we can see that the progression-free survival from the trial data is like that, and the treatment alternative was showing better health outcome in terms of PFS. And similarly, for overall survival, we can see that the treatment alternative was showing better, mean time to event is time to event in terms of month. In this case, is median from the Kaplan-Meier is 12 months, and for the placebo group is 11 months. So that's the evidence we use. And in terms of resource implication and cost, the manufacturer, they use this cost data for healthcare services use and trial drug cost, and also for health outcome, we consider the quality adjusted life year. That's the generic health outcome generally we use for economic evaluation. So the manufacturer, they use the quality or utility data from the literature, because the trial could not capture the quality of life score data, hence they use the published evidence. So cost effectiveness decision generally, we have got two alternative options. One is the treatment drug and the alternative drug. In this case, alternative and the best supporting care. So if the treatment is more effective and less costly, then straight away we can consider the new treatment. Whereas if the treatment is more expensive and more costly, so the question is how much extra cost is what is spending in order to gain one quality adjusted life year. That's the decision rule generally the policymaker they apply. So they calculate the incremental cost effectiveness ratio, and then they compare with the willingness to pay threshold, that the one I just mentioned, how much extra cost is what is spending for any drug to be considered as cost effective. So that's the willingness to pay threshold that generally the regulatory body they use in the UK, it is up to £30,000 per qualigain. So in this case, we use that decision rule. And then we have found we have done the structural uncertainty in the model based on these 3 types of transition probabilities. One is fixed unlink, another one is fixed link, another one is time variant, because the transition from one state to another state could be time dependent. And you can also for fixed link, like, whether the transition for treatment group is based on the relative risk compared to the placebo group in terms of progressing from one health state to another health state. So the 3 probabilities from progression to progress state and progress to death and progression free to death, these 3 probabilities can be modeled using these 3 different approaches we considered for the structured model. So one is the fixed unlink, fixed link, and the time variant transition, which is based on some parametric approach. We can consider some other parametric functional form using the functional form of the survival data. That is also possible, like Weibull, log logistic, and other parametric distributions. Anyway, so using the summary Kaplan-Meier data, we have fitted the observed survival observed frequencies, observed probabilities from the trial data, and then we have predicted the probabilities using the total sum square error minimization approach, mean sum square error minimization approach, using the Microsoft Excel server. So that's the approach we have used, and then we have seen that for all these three types of survival curves, and from these three types of transition probability approach, we are saying that the model actually predicted very well for both alternative treatment and the control group. And then we have used this for prediction, long-term prediction of the event beyond the trial period. So that's the that's the method we use in the Markov model, the cost effectiveness model. And that's what actually you can see the long-term prediction from the placebo, and long-term prediction for the treatment group. We can see that for the prediction, long-term prediction, actually the time-varying approach showing some sort of deviation in the prediction, and that shows the the one I just mentioned, that different functional form survival data can be possible. Hence, it is showing that actually time-varying prediction is a bit different from the fixed transition approach. So hence the result could be different. So that's what actually we have done. And then when we compared the results, now one thing actually I need to mention, that everything else remains same except the structural uncertainty in the model. Then we have compared our results with the manufacturer submission results, and then we wanted to see whether results are changed or not. So in terms of results, we have seen that the difference in cost and quality between these two alternative options. So we are saying that manufacturer model, which is in yellow color at the bottom, saying that it's showing that the intervention treatment or the new drug is more effective and more costly compared to the existing drug, compared to the base supporting care or the control. So it means that the treatment is more beneficial to the patient. At the same time, it is bringing more cost. So how much extra cost is what is spending in order to gain one extra quality? So in this case, we calculated ICER, incremental cost effectiveness ratio, which is 50,000 pounds per quality gain, that one the manufacturer produced. And in our case, in our restructured model, we have found that ICER is actually varied from 54 to 66,000 pounds per quality gain. So what it means that, basically the results showing that even from the manufacturer model, the treatment, the alternative is not cost effective. And we have also found that our restructured model was not showing that the treatment drug is cost effective. What we have found that the result is varied, depending on the different types of transition probabilities considered. So it did not change the cost effectiveness decisions, but there is a variation in results. So that's the key message we have found. And in terms of policy implication, I will just mention. So what we did, actually, we did some sensitivity analysis, because we have found that there are lots of uncertainties possible. We have changes one of the parameters at a time, and that's what actually standard practice we do in an economic evaluation. So that's what we have found, and from all these sensitivity analysis results are showing that the results are in expected duration, in line with the manufacturer submission model, and also in our restructured model, baseline restructured model results. None of them change the cost effectiveness decisions, but there is a variation in the results. So the key findings here we have found here that the cost effectiveness decision was not changed. The manufacturer's ICER value is actually even above the willingness to pay threshold. In our case, it is the same, but the result varied because of the different transition probability approach we have applied. What the main strength is, we have used the summary data, we have modeled this summary data, and we have predicted this long-term resource implication and health implication of the treatment of the drug which is showing very accurate results in terms of the direction of the results and also the range of the results. One limitation of the study is we could not consider a probabilistic sensitivity analysis, which is very standard practice, because we could not find the distribution of the parameters in the model from the public access report we have used for this exercise, for this study. So that's the only limitation. Now, in terms of policy implications, also in this case, I mean, if we look at the impact in broad perspective, in this case, possibly the cost-effectiveness decision is not changed because the ICER value is far above the willingness to pay threshold. But for those technologies where the ICER value falls on the boundary side, or even less than the willingness to pay threshold value, then this research actually has got huge impact because that could change the cost-effectiveness decision. So the decision could be like the treatment could be even cost-effective if the ICER value falls on the boundary of the willingness to pay threshold value. So that's the key messages. So this type of study actually can be replicated for any technology, anywhere in any healthcare system. I mean, if we want to do that. So that's the main message from me. And thank you for listening.
Thank you so much, Dr. Fassi. It was a very interesting presentation. We are already 1 minute over your time, but you had some problems. So I received one question. Sorry, I don't know who asked it, but I got it from the IT.
Okay.
Do you still have these samples that could be used for further analysis in a collaborative project?
Oh yes, definitely yes. As I said, I mean it could be used for any technology, any drug for any healthcare system, depending on the system has got the information for this type of patients, healthcare resource implications, all these things. Yes, it can be replicated, yes.
Thank you so much. So whoever asked this question, sorry for not knowing, because I just got the question sent. Please contact Dr. Fassi yourself, and maybe you can start talking to each other in person, at least virtually.
Yeah, I'm more than happy to do that, yes.
Thanks so much again. Sorry for kind of cutting you off, but we have to move to the next presentation. Thank you, Dr. Mohammed.
Okay, you're most welcome. Okay, bye.
Bye-bye. So I'm very happy to introduce our next speaker, who is Dr. Michael Nomikos. He is the section head of research and graduate studies in the College of Medicine. And his presentation will be in the field of reproductive medicine. So that's the only talk we have in that kind of field. So we are very excited. And the title of his presentation is Where It All Begins, Sperm, PLC-Theta, its vital role in fertilization and its potential as therapeutic intervention to treat certain forms of male factor infertility. So Dr. Michael, we are very happy to hand over the microphone. I see your presentation already. Please start your slideshow and please start. Welcome.
Thank you, Dr. Gerhild. Salam alaikum. Good afternoon, everyone. I would like to thank the organizer for giving me the opportunity today to present the work that we have been doing and represents one of my two main research interests. My research interest is, the first research interest is what you will see today, the role of calcium in the generation of a new life, so calcium in life. While my second research interest is how effects in calcium signaling contribute in cardiac disease and early onset cardiac death. So today I'm going to focus on a small sperm-specific protein that has been also termed the spark of life. And as we will see, defects in this protein can cause male infertility. And I will discuss about its potential as therapeutic intervention to treat certain forms of male infertility. So one of the earliest events during fertilization is a large, sorry, we have some technical problems here. Can you? So one of the earliest events during fertilization is a large transient increase in the levels of intracellular calcium concentration. This calcium increase is both necessary and sufficient for the completion of all the events of PEG activation, such as cortical granular exocytosis that aims to block polyspermy, resumptions of meiosis, and pronuclear formation. Without this calcium increase, fertilization cannot start, cannot begin. And in non-mammalian species such as sea urchins...
I'm sorry to interrupt you, Dr. Michael, but the slides are really funny. So could you please...
Our technical assistant here is trying to fix this because I'm presenting on the camera, yes.
Yes. I don't know whether it's worth waiting for your slides or...
It's almost there.
Okay. Yeah, sorry for this.
Sorry about this, we're trying to fix it. So I use my laptop.
Yeah, get your laptop, please.
Let's go ahead and share here. It's okay, Shusha, I will do it from here.
I'll do it from mine, don't worry.
Yes.
I will share from mine. Can you please make me a presenter? No. Make me a presenter. I present it directly from here.
I think you are present. Oh, yeah, make him present.
Is it working out there?
We can't see your slides yet, Dr. Michael. If you prefer, I could, I'm also not a presenter. Now something is coming up, yes. But we see the demo web export.
Now you will see.
Yes, I see it. Sorry everyone for this.
So, as I was mentioning before, without this calcium increase, fertilization cannot start. And in non-mammalian species such as frogs or sea urchins, this calcium increase has the form of a single rise, a single spike. However, in mammals, including humans, this calcium increase has the form of long-lasting calcium transient, as you can see in this schematic, known as calcium oscillations that start few minutes after sperm egg fusion. They last for several hours and they stop by the time of pronuclear formation. We have recorded a video of real time where we have, as you can see here, the fertilization, the in vitro fertilization of 8 mouse oocytes. I'll try to play this video. You can see here the mouse sperm trying to fertilize these 8 mouse eggs. And at the same time, we have used calcium dyes and we have recorded this calcium oscillation. You can see the color change inside the cytosol of these eggs. And this is the calcium phenomenon that I described. Without this phenomenon, we cannot start fertilization. And over 100 years, scientists tried to understand this phenomenon, and many hypotheses had been proposed and many molecules had been suggested that the sperm factors that causing this calcium release before the initiation of fertilization. Although there were promising candidates, none of these could mimic the calcium oscillations that we observe at fertilization. And it was the year 2002 when I got a scholarship from the College of Medicine in Cardiff University, and I joined the group of Professor Anthony Lai, where his group just discovered a novel phospholipase C isoform, sperm-specific phospholipase C isoform, as the sperm factor which is responsible for triggering this calcium oscillation in mammalian eggs. And this animation represents how PLC zeta triggers these oscillations. So after sperm egg fusion, phospholipase zeta is released in the egg cytoplasm, catalyzes its membrane-bound substrate, phosphatidylinositol biphosphate, producing 2-second messenger, diacylglycerol, and inositol 3,4,5 3-phosphate, IB3. The inositol 3-phosphate binds to inositol 3-phosphate receptor in the endoplasmic reticulum, changing its conformation with result to have calcium influx. The inositol 3-phosphate receptor is a calcium release channel inside the egg. We have used anti-PLC zeta antibodies and different sperm from different species. You can see pig, mouse, human, and we have used immunocytochemistry analysis. And as you can see, phospholipase zeta is localized in post-acrosomal equatorial region of every single sperm of different species in order to have rapid access when after sperm egg fusion to start hydrolyzing in substrate and causing calcium release. We have published numerous studies describing the biochemical properties of this unique protein. But I don't have time to go through on this, but I will give you a brief overview of its structure. PLC zeta is a small molecule, about 70 kilodaltons, 608 amino acid. It consists at the N-terminus of 2 pairs of EF-Han domains. These are calcium binding motifs and gives phospholipase zeta the unique property that has compared to other somatic PLC isoforms to be active at resting calcium levels when it just enters the egg cytosol. The 2 catalytic domains X and Y, which are responsible for the hydrolysis of its substrate, PIP2, and they are linked together by a small unstructured region of about 50 amino acids that contains many basic residues. And finally, the C2 domain at its C-terminus, which is a phospholipid binding domain targeting phospholipase zeta to the membranes to find its substrate and hydrolyze it. We also have used immunostaining analysis, and we have shown that compared to the other phospholipase isoform, phospholipase zeta, instead of being localized in the plasma membrane, is localized in intracellular vesicles. And we have shown, although before was thought that PIP2, this substrate, is only found in the plasma membrane, that there are sources of PIP2 inside these cytosols. And we think that we have already identified, we need some experiment, and we are ready to publish which is this organelle that phospholipase zeta is localizing and hydrolyzing its substrate. Another more important property of this novel phospholipase isoform that is capable of triggering calcium release in eggs and not in somatic cells. When we transfected YFP tagged PLC zeta in somatic cells, in CHO cells, Chinese hamster ovarian cell line, as you can see from the color of these cells, phospholipase zeta was successfully transfected. We also used Western blot analysis to show that this protein was also successfully expressed in this cell. And we used cell extracts, and we did an in vitro enzymatic assay, and we showed that this protein was enzymatically active. We were unable to see any calcium changes in the cytosol of these cells. However, when we injected cell extract into mouse oocytes, we were able to see these calcium oscillations that we see during fertilization. And even more importantly, when we injected whole single cell that we had transfected with PLC zeta into mouse eggs, we were also able to see the same response that we see during fertilization. It's like by transfecting the somatic cell with PLC zeta protein, you can convert it into a sperm. And this can have two meanings, either that there are factors in somatic cells and sperm that inhibit PLC zeta function, that's why it cannot cause calcium release, or there are other factors within the eggs, within the oocyte, that favor PLC zeta, are requirements in order to be active. And this can have serious links to unknown cases of female infertility. So one of our major goals is to try to identify the egg partners inside the cytosol of the egg, of PLC zeta. And here I will show you some unpublished data. We're preparing the manuscript to submit to JBC, that we have identified one of these binding partners of PLC zeta. You can see, this is immunocytochemistry experiments. You can see the localization of PLC zeta in human sperm, and we have identified that another calcium binding protein, small calcium binding protein, calmodulin, co-localizes, as you can see, the right panel with PLC zeta inside the human sperm. And we have also mapped this interaction. We have used state-of-the-art technique, isothermal titration calorimetry, and we have found the exact region of that PLC zeta interacts with calmodulin. And more importantly, we have shown that this calmodulin binding to PLC zeta inhibits its enzymatic activity, playing a regulatory role when we have increase of the calcium. But now you will ask me why it is important you saw another protein. What is the clinical significance of what you have found right now? Since 2008, more and more studies, this was the first study that was published in the Journal of Clinical Investigation, that showed that reduced expression level of PLC zeta in human sperm can lead to failed fertilization. Since then, more and more studies reporting cases from Europe, China, Tunisia. There are too many papers. These are two very recent papers, 2020, that they have identified other infertile males with defects in PLC zeta, either reduced amounts of PLC zeta or mutated forms. As we know, we have now the IVF clinics, and one of the most powerful techniques that they use to overcome such cases of male infertility is called intracytoplasmic sperm injection, or ICSI. By this technique, we have direct injection of sperm inside the egg cytosol. So if we have any problems with morphology or motility of the sperm, they can be overcome by this powerful technique. However, and as you can understand, when we have problems, defects on PLC zeta, even this technique will not be able to help. And at the moment, the IVF clinics are using calcium ionophores. These are some chemicals in order to overcome this problem in cases of failed fertilization. But the problem with these calcium ionophores is that they, instead of eliciting the physiological pattern of calcium oscillation, they just produce a calcium wave, one single spike, and we don't know the effect on the later embryo development. Still, there are not many studies to prove that this is a safe way to proceed with in vitro fertilization. So the best way is to use the physiological agent in parallel with the injection of the sperm to inject the recombinant human PLC zeta. And this was a very difficult task, but we managed to produce it in bacteria with a tag and utilization substance A. This is the most soluble protein in E. coli. As you can see, we produced it. You can see that they expressed nicely. It was enzymatically active in vitro. But more importantly, when we injected mouse and human eggs, we did see this nice response mimicking the fertilization. And even more importantly, without sperm, just with this protein, we reached to not only fertilization, but to embryo development, and we got up to blastocyst stage. We cannot go further because sperm is missing, so this is haploid. Not only this, we use this protein as a prototype model to treat cases of male infertility. So we used PLC-zeta protein RNA from a patient from Belgium, an infertile patient, and you can see this patient had 2 mutations in his PLC-zeta gene, and we lived these 3 hours. As you can see, we couldn't have any fertilization or any calcium oscillation, and after 3 hours, we injected human phospholipase zeta protein, recombinant protein that I showed you earlier, and as you can see, we successfully rescued infertility and leading to blastocyst stage. Very recently, we have published some papers that we show how important is PLC-zeta and its potential as a diagnostic tool to diagnose cases of male infertility and also used as a therapeutic agent. So our future goals is to use recombinant PLC-zeta protein, as I said, to screen Qatari population by DNA sequencing or other immunodiagnostic techniques. We have developed very good PLC-zeta antibodies, and to treat patients that we've identified by a double injection of sperm with PLC-zeta protein in order to make the first PLC-zeta baby in Qatar. And here I would like to thank everyone that has contributed on this work. We also want to screen COVID patient samples to see if there is any effect on this protein. Thank you.
Thank you so much, Dr. Michael. This was an excellent presentation, and thank you for sharing even your unpublished data with us. I know you had some technical difficulties, but if is there anyone who would like to ask a question? Either you raise your hand or put it in the chat now. Well, then I just have a very quick one, Dr. Michael.
Yes.
You were mentioning you will want to have the first PLC-zeta baby in Qatar. Are there any concrete plans about that already?
Yes, we're working on it on IRBs, and we have our collaborators from Hamad Hospital. The thing is that lately, with my administrative roles and mainly I have put more weight on the cardiovascular project because it's more priority in Qatar. But we have one PhD student together with Professor Mr. Aladdin Salek that working on this project, and hopefully we will try to progress with this as well.
Okay, thank you. If this would happen, it would be a major news. So good luck with your project.
Thank you.
So, sorry, there is one question coming up, Dr. Michael.
Yeah, sure. Sure, I'm here.
You have, it is from Dr. Alla. So do you have any idea about the role of PLC on cell-cell adhesion and therefore cell migration?
No, we don't know, but because I know Dr. Alla is working with cancer, we might have an indication, or we may think that differential expression level might play a role in prostate cancer, and we have to investigate this.
Okay, thank you very much. I see Dr. Ottman also asked something, but please send a chat message or
they can find me and we can discuss this.
To Dr. Michael, because we are a bit over time, but this is not Dr. Michael's fault. We had a small issue. So thank you very much once more, Dr. Michael. And we move on to the last presentation of this session. It will be a presentation in the cardio field, and the speaker will be Dr. Soo-Min Chee. He is a professor at the College of Health Sciences. Dr. Soo-Min, we see your presentation slides already. That's good. So the title of Dr. Soo-Min's presentation will be The Association of Low Serum Magnesium Level, or serum magnesium with Diabetes and Hypertension, and Findings from the Qatar Biobank Study. So Dr. Soo-Min, I hand over the microphone to you, and please start, and thank you very much.
Thank you very much for the introduction, and thank you for the organizing committee for giving me the opportunity to present our study here. So as mentioned, the objective of the presentation is to look at the association between low magnesium levels with diabetes and hypertension, and using data from Qatar Biobank. So why magnesium? Magnesium is an important nutrient, and it's needed for the proper functioning of enzymes, and it has been shown that magnesium can improve oxidative stress, insulin sensitivity, and high intake of magnesium has been shown to be able to lower the risk of diabetes as well as the inflammation. And furthermore, the supplementations of magnesium has been shown to be able to lower the glucose levels when people have diabetes. Clinically, if someone goes to the hospital and have a blood test, and what the doctors use to define magnesium deficiency, actually they have this normal range is between 0.75 to 0.95. And the problem for this normal range is that it is not based on the health outcomes. It's only based on the distribution of serum magnesium in the normal population. So that is why subclinical magnesium deficiency is common, and it is widely unrecognized. But this subclinical deficiency has been shown to be associated with hypertension, diabetes, from studies conducted in Europe or US or some Asian countries. And for the magnesium nutrition, the main source of dietary magnesium is from the whole grains, legumes, and nuts, etc. And in our modern diet, modern society, the problem is that our magnesium intake is lower than the recommendation. It's because we are consuming refined grains, and we know that in refined process, the magnesium is lost. And surprisingly, the dietary magnesium intake, the data in Qatar, actually we don't know because it's not being calculated, and we cannot find from the publications. So in this study, we used data from Biobank, Qatar Biobank, and to assess the association between magnesium in the blood with hypertension and diabetes. We all know that Qatar Biobank, it's an excellent study, a large study conducted at Qatar, and it started in 2012, and it includes adults aged 18 and above, and it uses a variety of tools and methods to collect information, including self-administered questionnaires, the nurse interviews, and the blood sample being tested, etc. So it's a rich source of data. And in this analysis, the analytical sample, we include Qatari aged 20 years and above, and if they have measurement on serum magnesium, and if they have completed a food frequency questionnaire. So the total sample size in this analysis is quite large. It's almost 10,000. For the definition of diabetes, we've used the conventional way to define based on the fasting glucose or random blood glucose or HbA1c, etc. And for the pre-diabetes, we use HbA1c between 5.7 to 6.4, and we also calculated insulin resistance based on HOMA model. And we define a HOMA model value above 2.8 as insulin resistance. And for the exposure variable, the serum magnesium is measured. And for the definition of subclinical magnesium, we use a cutoff of 0.85 because this value is actually is based on an expert paper published in 2016 from the US. And in the analysis, we are able to control or adjust for a range of covariates, including self-reported smoking, physical activity, education, or family history of diabetes. And for hypertension, we based on the measurements. For chronic kidney disease, CKD, we define based on the eGFR below 60. And in the statistical analysis, because the prevalence of diabetes is above 10%, so we use the Poisson regression with robust variance to estimate prevalence ratio instead of odds ratio. And we also tested the interaction. The analysis was conducted using Staler. So in this sample, the mean age is around 40 years old and half were women. And the prevalence of diabetes is 18.9 and slightly higher in women. And known diabetes is about 17%. And among the known diabetes, the average duration of diabetes is almost 11.5 years. And a quarter of them are using insulin to manage their diabetes. So this slide shows the distribution of serum magnesium. If we look at the figure here, we can see clearly that the distribution, a high proportion were below the 0.85, and the value is almost 60% of the population had the value below 0.85. And if we look at the those with diabetes, then the prevalence of subclinical magnesium deficiency is 77% in the population, in the sample. And there was a strong inverse relationship between the level of serum magnesium with diabetes. If you look at this table, across the quartiles of serum magnesium were from low to high. Actually, prevalence of diabetes dropped substantially from the 34% in the first quartile down to 10% in the highest quartile. And the trend was also similar for insulin resistance or the insulin use or hypertension, so across the levels of serum magnesium. So in the multivariable model, after adjusting for covariates, if we look at the figure here, the figure shows the prevalence ratio, and we use the highest quartile of serum magnesium as reference here. If we compare this high with the low, we can see that there's a strong dose response relationship here between the magnesium level and diabetes. So the lowest quartile almost have 2.7 times more likely to have diabetes. So, and this same trend was also observed for the undiagnosed diabetes. Among those with low magnesium level, the first and second quartile, the likelihood of having undiagnosed diabetes is more than doubled. And the trend was also true for the insulin resistance or poor control of diabetes among those with known diabetes. There's a dose response relationship here. And we found actually serum magnesium was associated with hypertension. The higher level of serum magnesium, the lower likelihood of having hypertension. But what is interesting here is that we found the serum magnesium levels interact with hypertension. If we look at this figure here, among those with high magnesium level in the blood, actually the probability of having diabetes is quite low. It doesn't matter actually whether someone has hypertension or not. But if the serum magnesium level is low, and if someone has hypertension, then the likelihood of having diabetes is much higher. And if we use the usual cutoff in the hospital setting, the 0.75 as cutoff among those with hypertension, the probability of having diabetes is 40%. And this slide shows a interaction between the continuous variable of systolic blood pressure with serum magnesium. And it clearly shows that there's an interaction. And when the magnesium level is high, it doesn't matter actually what your systolic blood pressure levels are. The risk or the probability of diabetes is low, but if the serum magnesium level is low, then the higher the systolic blood pressure, the higher probability of having diabetes. So that's the interaction with systolic blood pressure. So what happened to the diastolic blood pressure? The interaction still exists here. We can see a clear similar pattern. So to summarize the findings from this study is that we can see this is the first large study on the magnesium and diabetes in the region. And the findings are consistent, I will say, with the current knowledge from the other countries, other regions. And there are many possible explanations and mechanisms for these findings because, as I explained earlier, magnesium is antioxidant and can increase the insulin sensitivity and reduce the inflammation levels. And the interaction between magnesium and hypertension is quite interesting and important because among those with hypertension, 40% had diabetes when the magnesium level is at the level of 0.75. And in the population, the high prevalence of subclinical magnesium deficiency is actually, the burden is higher than the neighboring country. For example, in Iran, actually, the deficiency is much higher if we use the same cutoff. And in the data set, we did find the duration of diabetes was associated with the magnesium deficiency. It may be due to the renal dysfunction and causing the magnesium loss. But there are also other possible explanations that we are consuming high amount of refined grains. And there's another thing important and specific for the region is that we are consuming, using desalinated water, and the level of magnesium in the drinking water or the water supply is quite low. It's around 4 milligrams per liter. And according to the WHO, the recommendation, the amount should be around 15. So we had quite low levels in the drinking water. So that could be one of the important reasons for the low level of magnesium. So the strength of the study is, well, it's large, the sample size, and we are able to control a variety of confounding factors. And the limitation for this study is that it's a cross-sectional design, and although we have food intake data, but it's only, we have the frequency intake, we are not able to calculate the actual magnesium intake. And we don't have detailed information of medication use. So that's the limitations. So to conclude, from this large population-based study in Qatar, we can see that subclinical magnesium deficiency is common, and it's associated with diabetes and hypertension. And further, longitudinal studies or intervention studies are needed actually to elucidate the role of magnesium in the etiology of diabetes in this population, because the burden of diabetes is really high in the population, and the risk factors are not well understood. So I would like to thank my co-author, Dr. Abu Samra from Hamad Medical Corporation, and I would especially thank Qatar Biobank for providing the data and the advice from Dr. Asma Athani and Dr. Nahar Afifi. And it's a great pleasure to work and to analyze Qatar Biobank data. It's an excellent source for epidemiological studies. So thank you. That's my presentation, and I welcome questions from the audience. Thank you.
Thank you so much, Dr. Sumin. That was really interesting. I didn't know that there is a correlation between magnesium and serum levels and diabetes. So we got a question, but before I ask the question, could I ask, please, all attendees to open your camera, mute yourself. Do that, please, because we would like to take a group picture after Dr. Sumin has answered his question. And please smile when we do so.
Yeah.
I just saw a photo of me before. I looked totally serious. Yes.
Yes, Gerald. After the question answers, we can bring them in, everybody to panelists, and they can turn on the mic and video. But just finish your question answers first, please.
Yes. So I received one from Dr. Osman, and he was asking, what are the considerations when taking a magnesium supplement, as there are many forms of magnesium supplements, and are they chelated forms or better absorbed or more efficient than the non-chelated? So Dr. Sumin, maybe you could kindly answer that.
Yeah, the clinical trials that use different types of magnesium supplements in other countries, in other regions. It's being well documented, but there's no such study being conducted in Qatar. We don't know which form is more effective, and the special thing to consider is that in this population we are using a lot of supplement of vitamin D and calcium, and these supplements may interfere the absorption of maybe magnesium supplement.
Okay, so needs to be investigated. So please keep on opening your camera. The photo shoot is coming up. One more question for Dr. Sumin, and smile, because then you will have a lunch break till 1 o'clock. So Dr. Rafif also asked a question. A lot of studies showed that Qatar population has low vitamin D as magnesium assists in activation of vitamin D. Have you ever looked to the vitamin D levels in these candidates? Do you think this low magnesium may lead to low vitamin D as well?
Yeah, maybe they are interacting each other. I haven't looked at the vitamin D level yet, but I will explore. Definitely, it's a good direction to look at. Okay, thank you very much, Dr. Sumin. So we are almost closing the session. Please stay on your camera so that the photo can be taken. And with that, I would like to thank all the speakers of this session. You did an excellent job. Thank you so much. And we close this morning session now, and we will have half an hour lunch break. And please be back at 1 o'clock for the afternoon session and the next 4 podium presentations. So thank you, everyone. And enjoy your break, and see you back at 1 o'clock.
Thank you, Gerhild. Well done.
Stay, guys. Stay, guys.
Thank you. Thank you, guys.
We're taking picture right now.
Can I see? Okay. So we're gonna take the picture right now.
Yeah, looking good, everyone. Thank you. Are we done or are we still taking photos?
We have taken the video. Thank you. Thank you.
Thank you very much, everyone. See you. Bye-bye.
Bye. Be the host to leave. No, keep it.
questions or if you want to
Dr. Maggie, can you hear me?
It's push 15. It's
Yes,
16 minutes or 17 minutes and 3 minutes.
Okay.
3 minutes.
Today I noticed
3 minutes. So we're doing it at 17 and 3 minutes.
Okay.
Dr. Maggie? Dr. Maggie?
Are you able to hear me?
Yes, we can.
Dr. Maggie,
Yes.
can you present now?
You can start, Dr. Maggie.
We're starting it now?
No. Just joking.
Oh, perfect. Here you go. And turn on your camera. Very excellent.
Yeah, it's better to see from here.
It feels really good to be able to see you from here. Definitely just check. You never know. You might be able to do something. It's worth it. It's not too much.
So, Dr. Maggie, can you hear me?
Yes.
Okay, great. Thank you.
What time do you start?
Now, I think.
Now for a month,
No.
I'm not allowed to put any
1 o'clock?
makeup
At 1.
when I grow up. It's fine. But you can. I went to the banana yesterday. Yeah, and I smell. After only
Okay. Good afternoon, everyone. My name is Asad Zidan. I am from College of Medicine, CMED, and I will be chairing today's afternoon sections. The topics will include cancer, cardiovascular, medical, or health education. Our first speaker will be Dr. Maggie Haj. She is the Clinical Associate Professor and Associate Dean for Academic Affairs at Qatar University College of Pharmacy. She earned her bachelor degree of pharmacy in 2005 and the doctor of pharmacy degree in 2006. Her talk entitled will be Assessment of an Intensive Education Program on Treatment Tobacco Use Disorder for Pharmacists using OSCE. So, Dr. Maggie, the floor is yours.
Okay. Thank you so much, Dr. Asad. Can you all see my slides?
No.
Share screen again.
Please share.
Okay. So can you see my slides now?
Yes.
Okay, thank you so much, Dr. Asad, for your introduction, and thank you so much, everyone, for joining us this afternoon, and for inviting me. Thank you so much for inviting me to present today. So basically, today I'm going to present the results of one of the projects that we completed last year at the College of Pharmacy at Qatar University. It's under the title of Assessment of an Intensive Education Program on the Treatment of Tobacco Use Disorder for Pharmacists using OSCE, which is the Objective Structured Clinical Exam. So I have no conflict of interest to disclose. Just before I start, the research team, we have a big research team. It includes myself, Dr. Ahmad Awaisu, Dr. Nader Khair from Ajman University. We had an international consultant in tobacco cessation, Dr. Haniki from Malaysia. We have Dr. Rana from QU, Dr. Noor Al-Hamad from Sidra Medicine, and Dr. Ziad Mahfoud from Weill Cornell. Let me start with some background information. As you might know, tobacco use is a major preventable cause for mortality and morbidity in Qatar. So if we look only at the data from the 2013 Global Adult Tobacco Survey, 12.1% of adults and 20.2% of men smoke tobacco, and 55.4% of smokers in Qatar, they smoke an average of 16 cigarettes per day. More about the burden or the morbidity associated with the tobacco use. Tobacco-induced diseases in Qatar, including cardiovascular diseases, are highly prevalent. So if you look only at the mortality rate from cardiovascular diseases in Qatar, from 2011 to 2013, it was 8.3 per 100,000 for Qatari males aged between the 20 and 44 years. Lung cancer is also one of the main causes of cancer-related mortality in Qatar in males, accounting for 17.4% of the cancer-related deaths according to the data of 2014. In addition, we have some data that show that Qatar residents, they buy at least 1 billion cigarettes per year, and $150 million are spent per year to cover the hospital fees for smoking-related diseases. So to reduce the use of tobacco, Qatar has been really very active, and the Qatari government are really proactive, and they ratified the World Health Organization's framework Convention on Tobacco Control. So they implemented several measures, as you might know, in Qatar. For example, they banned selling tobacco products for basically people who are less than 18 years old, banning smoking in closed places, including malls, putting taxes on the import of some tobacco products. So Qatar is really doing a great job in implementing tobacco control measures. However, despite these initiatives, tobacco use is still considered really an issue and a public health threat in Qatar. So Qatar pharmacists really have an excellent opportunity to reduce tobacco use in the country. So as you may know, they are one of the most accessible healthcare providers. So we can just drop by a community pharmacy and just ask for advice from a pharmacist. So currently, according to the database that we have from the Ministry of Public Health, we have over 1,000 practicing community pharmacists in Qatar. And as you know, majority of medications in Qatar are available over the counter, including the ones for smoking cessation. So you will see in community pharmacies basically Varenicline, Champix or Chantix, and we have the nicotine replacement therapy, basically as lozenges, gums, and patches. And all of these are over the counter. And this really makes an opportunity for pharmacists to assist, advise, and assist patients in basically smoking cessation. There are many studies, if you go over the literature, that really demonstrate the effectiveness of pharmacist-delivered smoking cessation interventions. I'm just quoting here one meta-analysis done by Dr. Maya Saba and her colleagues in Australia. They conducted a meta-analysis of the effectiveness of pharmacist-delivered smoking cessation interventions in community pharmacy, and they have shown that community pharmacy-based smoking cessation interventions can improve smoking abstinence rates. And this is only one meta-analysis. There are others you can see over the literature. We've done a few years back a study in Qatar to see what's the status of Qatar community pharmacists in smoking cessation. And we have seen that a very small percentage of community pharmacists in Qatar, they ask patients about their tobacco use or smoking status, and less than 50% they offer counseling to patients who are buying the nicotine replacement therapy. And when we ask them about their education, whether they received any kind of education, whether in their undergrad studies or postgrad studies, or even as CPDs, like 89% said that they have never received any kind of education or training about smoking cessation counseling in the past. The good news is that 85% of the pharmacists were really interested in receiving additional training. So this basically brings us back to the objectives of the study that we had. So the aim of our study, which was a randomized controlled study, was to design, implement, and evaluate an intensive education program provided by a team a multidisciplinary team of health professional educators on tobacco use treatment for pharmacists in Qatar. So the primary objectives of the study, we had primary and secondary. For the primary objectives, we assessed the effectiveness of this program on the knowledge of the pharmacist and skills in relation to tobacco and tobacco cessation. We assess their knowledge and skills in two ways. One of them is through a validated multiple choice knowledge instrument and an objective structured clinical exam. For the sake of time for this presentation, I'm only going to share the results of the OSCE. So in terms of the study design, we had a prospective randomized control trial comparing the effectiveness of the education program of the pharmacist, basically, who attended the training program versus the knowledge and the skills, tobacco-related knowledge and skills for the pharmacist who attended a non-tobacco, basically, CPD or education program. So who were eligible? Eligible participants were any pharmacist practicing in Qatar. We didn't really have any exclusion criteria. So we got of course, the ethics approval, and we got from the Ministry of Public Health database a random sample of 200 pharmacists. We stratified them by pharmacies because we didn't really want to have more than one pharmacist at a time, like from the same pharmacy. So pharmacists who basically were randomly selected, we called them, we just explained for them like the study, and we sent them brochures about the study. And those who consented, they were randomly allocated to either intervention or control group. So this is a general flow chart of the study methodology and process. So after basically randomly selecting eligible participants, we randomized the pharmacists into intervention group and control group. So the intervention group, both of them, we had like a pre-baseline knowledge, attitudes, and self-efficacy assessment using instruments. And then the intervention group, they received an intensive education program for tobacco education. It was over 4 days, which were equal 32 credits of CPDs. And we covered the different basically competencies. So we had basically our program for the tobacco cessation. It was mapped against the competencies for the evidence-based treatment of tobacco dependence by the Association for the Treatment of Tobacco Use and Dependence. So we did like a mapping for the different topics and objectives and the competencies we wanted the pharmacist to achieve by the end of the program. The program really covered different aspects like epidemiology, risks of tobacco use, benefits of quitting, the role of pharmacists, the trans-theoretical model of behavior change, application of the TTM model into case scenarios, use of NRTs, use of alternative medications. We also covered non-pharmacological treatment for tobacco cessation, developing action plans, monitoring, documentation, counseling, communication skills. It was really an intensive program over 4 days, 8 hours a day. The pharmacists in the control group, they received a session on contraception, which is different than tobacco just. And we also give them the pre-assessment for the knowledge and skills. After the implementation, both groups, they had, again, the knowledge questionnaire as well as the OSCE. So for the sake of today's presentation, we are talking only about the OSCE. So here we have just intervention, just pictures before the COVID-19. We had the luxury of sitting together and having a workshop together. So we have the intervention group and we have the control group. Okay, this is the OSCE. Just to brief you on the status of or things we have done in the OSCE. We had 6 cases. We had, as far as I remember, maybe 4 or 5 parallel, basically groups. It was a 12 hours day. So we had basically trained evaluators as well as trained assessors on how to assess parapharmacists in both the intervention group as well as the control group. We also had simulated patients who are also very well, they received very well and structured orientation and training in relation to tobacco cessation and in relation to the cases that we had. So we had the cases, basically the OSCE in the library, in the small rooms. Just to debrief you on the different cases, we had 6 cases. They covered different aspects of smoking cessation. One case was about a healthy patient, woman, no comorbidities, anything, just she's interested in stopping smoking. We had a case of pregnant woman who was interested in smoking. We also had a case of a teenager who is also a smoker. We had a case of basically a cardiovascular disease patient who was also wanted to quit. We had someone who is relapsing. He quitted and he's coming for relapse. And we had also someone who's not interested at all. He was like in the pre-contemplation phase of the TTM. He was not interested at all in quitting in the next 6 months. Just to give you an idea on the cases and the analytical checklist, the cases, we spent hours and hours and hours developing the cases and validating them, validating the assessment sheets. We had panel of experts in tobacco cessation who basically reviewed the cases. So I'm just here sharing with you the analytical assessment sheet for one of the cases only. So as you can see, it has different sections. We had developing report, how the pharmacist really developed rapport with the patient, gathering information like what are the things that the pharmacist asked the patient about, the option and the management strategies, including patient education, and finally monitoring and follow-up. We also had a global assessment, so we assessed the patient, the pharmacist, really communication skills like confidence, body language, organization, nonverbal expression, how much they were empathetic with the patient. So yeah, so that's just an example of how we assessed each case. Results. So in the intervention group, we had 57 patients. In the contraception group, we had 37. So at the beginning, we had a pre-sample size calculation of 60. However, many didn't ended up not showing, or basically they withdrew from the study. So these are the final numbers we got in the intervention and the contraception group, and intervention and the control group. Let's move to the results. So basically we had, this is case 1, which is basically the healthy patient who has no comorbidities. So as you can see here, the mean score for the different domains, developing report, gathering information, management strategies, monitoring, follow-up, and global assessment. So as you can see that the mean score for each of the domains was statistically significant higher in the intervention group versus the monitoring group. That's for case number 1. For case number 2, this was the patient, the pregnant patient. So basically, again, you can see for developing report, we have a statistically significant difference between the intervention and the control group. The same goes for gathering information, for the management strategies, for monitoring, as well as for the global assessment. Case number 3, which was basically the teenager who was a smoker and interested in stopping smoking. So you can see as well that again the domain of developing report was higher. The mean score was higher in the intervention versus the control group. The same goes for gathering information for 5.17, for example, versus 2.94. The same goes for the management strategies, monitoring, follow-up. For this case, the global assessment, there were no really statistically significant difference. It was quite tricky to communicate with a teenager who is a smoker for both groups. For the OSCE case number 4, basically this was a patient who had quitted. However, he's coming with withdrawal symptoms of nicotine, and nicotine withdrawal symptoms. Again, for developing report, there was statistically significant higher score in the intervention versus the control. The same goes for gathering information, management strategies, and global assessment.
Dr. Maggie,
Yeah.
you have 1 minute only, 1 minute.
Yeah, I'm finishing. The same goes, yeah, I'm finishing. For case number 5, the same as well, we had statistically significant differences. This was about the patient with cardiovascular disease. For case number 6, we had statistically significant results for the developing report and management strategies and monitoring follow-up. The total scores for the intervention and control groups, they all were statistically significant between intervention and control. So in conclusion, I think our study really demonstrated that it's feasible and it's really beneficial to implement an education program for training for smoking cessation. And I think efforts should be exerted to apply these programs for professional development of pharmacists in Qatar. Finally, I would like to acknowledge and thank all the pharmacists who participated, the evaluators, QU Health CPD team for accrediting our program, and finally QU Office of Research and Graduate Studies for funding us through a collaborative internal grant. Thank you so much for listening, and thank you for taking more time.
Thank you very much, Dr. Maggie. Very interesting topic. Just before moving to question, maybe we have one question. I want to ask about different aids to stop smoking. Do you have an idea? Just
different. I didn't hear you. Different. Sorry.
Aids to stop smoking.
AIDS. Yes.
Yes. In Qatar.
Yes, in Qatar, like if you go to the community pharmacy, you have the nicotine replacement therapy, which is over the counter. We have those. They have dosage forms like patches, gums, and lozenges. If you go in the States and other places, you might find the intranasal form and other forms, but I don't think these are available here. There's also the Champix or Chantix Vaniclean. It's also over the counter here in Qatar. So yes, these are the ones that you can find in a pharmacy. In terms of programs, there are many programs. You have in Hamad the tobacco cessation clinic. In PHCC also you have clinics, yes.
So what is the best, Dr. Maggie? What's your recommendation?
What's the best? I think it's a combination. It depends on the case, and it depends on how basically the patient is a heavy smoker or not. So definitely I would say a combination of medication therapy and the behavioral modification techniques are better than placebo, I can say.
Thank you very much. Thank you very much, Dr. Maggie.
Thanks.
So I don't have question and we don't have time. Thank you very much. Very interesting topic. So our next speaker will be Dr. George Hindi. Dr. George Hindi is assistant professor at College of Medicine. Dr. George Hindi graduated as a MD from American University Beirut, and he did his PhD from Lund University, Sweden, and then he did his postdoctoral degree from MIT, Harvard. The title of his speak will be Association of Exomes Sequence Variation with the Blood Lipid in 170,000 individuals across multiple ancestors. Dr. George?
Okay, hello everyone, and thank you for the introduction and for this opportunity. Okay, so I'll be telling you about a study that I have initiated during my postdoctoral work at the Broad Institute in the US, and which looked at association between rare coding variations and blood lipids using more than 170,000 exome sequences from multiple ancestries. Okay. So looking at the genetics of blood lipids, we have to think about what have been identified so far. And for that, we need to look at genome-wide association studies. And those started like more than 15 years ago. And so far, there has been more than 1,000 genomic loci associated with blood lipids. However, the challenge with these 1,000 loci and with another 187,000 associations that are linked also to other traits and diseases from genome-wide association studies is that these are generally of weak effect sizes, and very few of those they have translated into functional insights. In other words, very few of those loci have been linked to causal genes. They are usually in intergenic regions or in intronic regions, most of them, without any any functional insights. However, we have to keep in mind that there are certain opportunities from those. Basically, they have generated polygenic scores, and these were important for risk prediction and stratification. And they have been instrumental in the success of Mendelian randomization studies. And those are techniques that lead to causal inference between biomarkers and disease. On the other hand, thinking about genetic association studies, we have to think about those that look at rare gene-altering variations. And the success of those have been limited because of the high cost of DNA sequencing compared to the cheap array data in genome-wide association studies. But we should not skip certain successes, particularly the PCSK9 gene, where they found association between sequence variations. So rare protein truncating variations in this gene have been linked to low LDL cholesterol, and they have been found to associate with coronary heart disease. And this has been instrumental in generation of PCSK9 inhibitors, now established class of LDL cholesterol lowering drugs, and they have been shown in phase 3 trials to protect from heart disease and prevent heart disease. Similarly, ApoC3 is another success story with coronary artery disease, and currently there are drugs in development targeting this gene. And recently, ANGPTL3 also has been shown to have a protective effect or preventive effect on heart disease in phase 3 trials. So here comes the aim of this study. So we wanted to look at the association of gene-altering rare variants with circulating lipid levels in large data set with exome sequencing data. And we wanted to leverage also multiple ancestries. So most of the studies so far have focused on European ancestry, and we thought that leveraging people from other ancestries would would empower us to have data on new variants that could give valuable information on these associations. And with the aim of linking those code back to the aim of finding these rare variant associations is to see whether we will see other coding variants that have not been captured by GWAS so far, with the aim also of discovery of novel genes, and finally of linking these novel genes with heart disease. And for that, we used 4 large data sources from consortium, mainly the Myocardial Infarction Genetic Consortium, the Transomics for Precision Medicine TopMed, the consortium, the UK Biobank, and the Type 2 Diabetes Genetics Consortium. And we did, of course, extensive quality control in these data sets. We removed duplicates and relatives across these because there were many studies that are overlapping across these. And we ended up with around 44,000 for MIGen, 44,000 for TopMed, around 50,000 for UK Biobank, and 30,000 with type 2 diabetes samples. Some were population-based, and some were case control studies for like CAD with MIGen and type 2 diabetes with the type 2 diabetes genetics consortium. And after cleaning those data sets, so we did single variant association analysis in those by ancestry and case status. So we split each one of those by case status and each ancestry, and we did our single variant association analysis. We had around 15.6 million autosomal variants, which were used also for another analysis, which is gene-based. So we are looking here at rare variants, even though we had 170,000. So still, we needed to aggregate more than one rare variant in each gene to have power to see an association. So overall, we had more than 170,000 individuals. Still, most of them, they were of European ancestry. We had 30,000 of South Asian ancestry, 16,000 of African ancestry, 16,000 of Hispanic ancestry, and 10,000 of East Asian ancestry. We used software, computational software, specially designed for rare variant association analyses. It's called RV-tests. And we did ancestry and, as I said, case status analysis. We had in total 23 analysis sets. And each of the lipid traits, they were residualized on age square, sex. Also, we adjusted for the principal components, the top 10 principal components generated from the genetics of each study to adjust for population, any residual population stratification, also study and capture. And to maximize power, we wanted to keep relatives within each data source. So we generated kinship matrices using RV-test, the VCF to kinship script. And we applied linear mixed models incorporating these matrices to get the single variant association results. And for the gene-based results, because we are doing a meta-analysis, we had to generate also covariance matrices for each genetic region using RV-tests, using 500 kilobases sliding window for each gene, and these were needed for the gene-based meta-analysis in the rare metals. And after sample quality control, we needed also to do extensive variant quality control. So we had around 15.6 million autosomal variant of very high quality. And we needed to see which of those are can be annotated as protein damaging or gene damaging, protein truncating variants. So first, we did annotations using the variant effect predictor, and here we used the Lofty plugin. And this specific plugin finds with high confidence those variants that are likely to result in protein truncation, like stop gain, splice site disrupting, and frameshift variants. And we had a total of around 340,000. On the other hand, what to do with the missense variants? So missense variants are more challenging. Many of them, they can be tolerated, and they may not lead to damages in the protein. So we needed to leverage algorithms or bioinformatics software that predict how damaging a missense variant is. So we used two established definitions for damaging missense variants. The first one was based on these 5 different algorithms, and we found around 1.1 million damaging missense based on that. And the other was the meta-SVM, and using that, which is also based on 9 different algorithms, we identified around 700,000. And to empower our data and increase the number of damaging variants, we used a deep neural network, which is from Illumina, to identify splice site altering variants. And we could identify using that around 240,000 different variants that are predicted to be damaging based on this. So we moved to the single variant and gene-based meta-analysis. So we did both of these. So we meta-analyzed single variant associations using inverse variance weighted meta-analysis. And here we limited our data only to coding variants. So we did not care about non-coding sites. This was used for this was done using Metasoft. And with rare metals, we did the gene-based meta-analysis and filtering for variants that have been with the call rate more than 95%. And also we just limited to variants with a minor allele frequency below 1%. So we wanted to focus on rare variants. We did not care about common ones. And as I said before, we did the analysis by ancestry and case status. And we used 6 different definitions or masks, we call them, for the groupings of damaging variants. So this is like the most strict definition, but we will get few variants with this, so Lofty. So it's usually it's a trade-off. So we are sure that these are protein truncating, but we will have limited power. And then we started adding the other definitions that I talked about: splice site AI, damaging 505, and meta-SPM. And we did both burden and scat tests. And going to the results, so we're looking at the correlation between the minor allele frequency and the effect sizes on each of these 3 lipid traits. You could see there's an inverse correlation. And as you can see, with lower minor allele frequencies, you will tend to see a larger impact of variance on blood lipids. So the rarer the variance, the more impact, as expected, and as has been also reported in several other studies. And looking at novel single variant associations, we used a strict Bonferroni corrected p-value to define significant ones and to define novel ones that we put a 1 megabase region around each of the index GWAS signals based on these 3 genome-wide association studies. And we said everything outside these regions can be defined as novel. And we could find 6 novel missense variations in these 6 different genes. And doing some in silico lookups in the heart disease, in the coronary artery disease and myocardial infarction genome-wide association studies, these 2 in TRIM5 and ADH1B, they were associated with increased risk of heart disease and myocardial infarction. Then we moved to the gene-based associations. Also, we used a strict Bonferroni corrected p-value for the number of, for around 20,000 genes that we are looking at and the 6 different traits. And as you can see, the results here, we in total, we had 35 genes that showed associations with any of these traits. But the interesting thing, so this study started thinking about that we will get some ancestry-specific genes, that some genes will show specificity in certain ancestries, which is based on also the genome-wide association studies common variation, where they tend to show high heterogeneity across ancestries, and they are sometimes the effect sizes are different. However, with the gene-based meta-analysis, we saw consistency. So the most significant results, they came, as you can see, in the overall analysis. So which meant that all the ancestries are contributing to the final significant result, although different rare variants, of course, are coming from different ancestries, but they are contributing in a consistent way. And also looking at heterogeneity, I'm not showing this data here, we had very minimal heterogeneity in the effect sizes across ancestries. So this can be an important conclusion that can come from an exome sequencing study coming from this slide. Also looking at the 35 different genes over here, you can see that there's, of course, association with more than, most of them associated with more than one lipid trait. And of course, you can see the large circles are coming from the established genes like ApoB, ApoC3, LDL receptor, and PCSK9. However, we could identify 8 new genes based on this analysis, including albumin, CREB3L3, and so forth. Then we wanted to see whether what gene sets are enriched in our gene-based analysis. And we limited this analysis to Mendelian genes. So we went and collected which genes they are established to be associated with blood lipids in families. And we had 21. We also we wanted to see also GWAS genes, and we went and collected genes in the vicinity of GWAS signals. We had around 500 for LDL, 500 for triglycerides, and 500 for HDL. And also we looked at enrichment for drug-targeted genes. Using the drug bank as reference, we had 53 different drug-targeted genes. So for each of these genes in each of these 3 different gene sets, we matched it to 10 other genes based on the total number of individuals, total number of variants, the cumulative minor allele count, and the mask used. And from this slide, and here we see the enrichment of these different gene sets in our gene-based meta-analysis. And as expected, looking at the Mendelian genes and coding GWAS genes, we observed very high enrichment, and this is expected in our data. But the interesting thing, looking at non-coding GWAS signals. So here, these are index variants from GWAS that are not coding, and we ranked the genes based on the proximity to the index GWAS signal. So the genes that are closest to the GWAS, here the genes that are second closest, and this is the 3 or more closest. And what we could see is that the genes that are yeah. Sorry.
You have 1 minute, please. 1 minute.
So it was the highest enrichment for those genes in the closest GWAS, non-coding GWAS signals. And also we looked at the genes that were in proximity of the GWAS signals, and we also obtained 3 novel gene-based signals based on this. And when looking up in the coronary artery disease exome sequencing study, we could identify 2 novel genes that are associated with coronary artery disease, PLIN1 and AV5. And to summarize, we did the largest exome sequencing study for lipid rates, and possibly we think that is for any continuous quantitative trait. We replicated well-known lipid-associated signals, and we discovered new genes. We also found enrichment of the closest genes to GWAS signals or non-coding GWAS signals in our gene-based associations, and we found 2 new genes that could be valuable target for coronary artery disease prevention. Our study, of course, supports larger exome sequencing studies in multiple ancestries. They will likely empower these associations, and causal genes are important for cardiovascular disease prevention. And to do function, and we recommend functional validation of GWAS loci should prioritize genes closest to GWAS index variants. And these are my acknowledgements, and thank you for listening.
Thank you very much, Dr. George. Very interesting data and very big study. So my first question to you, are you planning to do the same analysis here in Qatar, especially we have a Qatar, biobank?
We hope so, to incorporate other ancestries in the study, I think, and as we have seen, of course, they will empower novel signals and identification of novel genes. So I hope to incorporate, of course, the data from the Qatar Biobank in this meta-analysis.
Yeah, especially I haven't seen any data from Middle Eastern genes.
So there has been some like family studies, and actually in Lebanon there has been some family studies with familial hypercholesterolemia and other lipid disorders, and they found basically some new variants, but in known genes, but nothing like in that scale that has happened, I think. So there is a deficiency in individuals of Middle Eastern ancestry in these large meta-analyses, and this should be overcome and should be addressed, I think. And they should, because it would also add to the, I think, benefit for the populations here. So maybe certain genes could be specific to the populations here, and could improve, I think, lipid targeting and heart disease prevention.
Thank you. I have a question here for you. Just we should go very fast. May we know what do you mean by non-coding? Does it mean available?
So non-coding is not in the exome region of the gene, and it's not. So it is like non-synonymous. So all intergenic regions and intronic. That's what I mean. Intergenic and intronic variants.
Thank you very much, Dr. George. Thank you very much. Really appreciate it. So our next speaker will be Dr. Apostolos Zaravinos. Dr. Apostolos, he is an associate professor of genetics in the Department of Basic Medical Sciences, College of Medicine. He received his first degree in molecular biology from Department of Biology, University of Crete in 2004, and his PhD in medicine from College of Medicine in 2008. So the title of his talk will be Mutational Signatures Across Distinct Cytocatalytic Subgroups of Colorectal Cancer. So Dr. Apostolos.
Thank you very much, Dr. Assad, and thank you very much to the organizers for this kind of invitation. So today I'm going to talk to you about mutational signatures and contagions across distinct cytolytic subgroups in colorectal cancer. Colorectal cancer is the third most common type of cancer among both genders, and the second. In the 1990s, Vogelstein and Tal proposed this so-called Vogelgram, which explains how a normal will transverse into adenoma, and of further mutations, we will have the appearance of cancer. So these mutations, or hits, as they are called, take place in well-defined stages within an individual cell. And now we know that there's different types of colorectal cancers, the majority of which, about 80 to 85% of which are characterized by chromosomal instability, where we can find mutations in oncogenes such as APC or KRAS, as well as mutations in tumor suppressors such as TP53. Colorectal cancer, about 20% of colorectal cancer cases is characterized as a CpG island methylator phenotype, because we can detect methylation in the promoter of genes such as MLH1, P16, and MGMT, which are accompanied usually by BRAF mutations. So these cases are characterized by epigenetic instability. In addition, about 15 to 20% of the CRC cases have mutations in these genes, MSH2, 6, MLH1, and PMS2, which are genes that take place in the mismatch repair system. So when this system is deficient, this leads to satellite instability, as we call it, and the accumulation of further mutations. So we can now, with the whole advent of the exome sequencing analysis, we can analyze the genomes of the colorectal cancers, and we can actually get a good hint of what mutational processes take place into these genes. So, for example, here in this cartoon, you will see the lineage of one single cell. Brown color stands for an already malignant transformed cancer cell. So here, when it has already become cancerous, you will see that it has already accumulated a whole bunch of somatic mutations, some of which, if we go back into this lineage, will also be identified, however, in the premalignant state, which is highlighted in blue color. So we can explore the mutational processes or mutational signatures that happen during these lineages. For example, one hypothetical mutational process would be this one, which is characterized by these black types of mutations. There's 6 different types of mutations, which I will explain in a while. And this mutational process has a weak but constant endogenous signal throughout this cell lineage. Another type of mutational process might be characterized by these red and purple type of mutations, and the signal might be intermittent but strong, meaning that it appears in a specific time frame within this cell lineage. One such example is mutational signatures characterized by tobacco smoking. Another mutational process might be this one, which is where we can find predominantly mutations of green and purple orange, and these can have a moderate but intermittent signal. So all these different mutational processes, and I don't mean that there's only 3, there can be many more. All these mutational processes, what they do is that they cooperate all together, and they, in the end, they give us the final list of mutations that we get when we analyze the cancer genome. And as you will identify, the final cancer genome has little or no similarity at all with any of these specific mutational processes. So what we are doing when analyzing cancer genomes is that we get this final cancer genome, and we're trying to go back in time and identify which mutational processes affect the appearance of this specific type of cancer. And we have to make an assumption here that the contribution of such mutational signatures is different from cancer type to type, but also within different patients of the same cancer type. And all these mutational signatures have already been cataloged at the Cosmic Catalog of Somatic Mutations in Cancer. We now know that there's at least 30 different mutational signatures, which have been cataloged according to the base before and after the spot where the mutation takes place. And there's 6 different types of mutations, as you can see here on top, C2A, C2G, and so forth. And the list is growing. What's interesting is that we now know more or less which mutational signatures affect different types of cancers. So, for example, in these 35 or so different cancer types, signatures 1 and 5 are predominant across all different types. Regarding colorectal cancer, so far, signatures 1, 5, 6, and 10 have been identified to play one role in this tumor. So speaking of mutations, I will get you to another point, which is categories. Categories, it took its word from the Greek word for thunderstorm. It's been used to describe localized hypermutations. And to better explain what categories is, I will present you these so-called rainfall plots. So each dot here is one different type of mutation. As I told you, there's 6 different types of mutations corresponding to 6 different colors. On the x-axis, you see it's actually the genome starting from the P arm of the first chromosome going down along the long arm, Q arm of the Y chromosome. And on the y-axis, what we see is the distance between one mutation to the other. So it's called the intermutational distance. Now, these mutations more or less are 3,000 mutations. And given that our genome is composed of 3,000 million base pairs, one would expect to find one different mutation in more or less 1 million base pairs. And that's what's happening here. But in some cancers, we have noticed that there's a specific chromosomal parts of the region of the genome that accumulate specific tremendous number of mutations, such as in this cancer genome. You see a plethora of C to T transitions, mainly localized on chromosome 6. Another rainfall plot is this one where you can see different parts of the chromosome that have these trickles of mutations. So it's as if it's raining mutations, so that's why we named it categories. So this and these are characteristic categic patterns. What else is characteristic for them is that they never happen in the same place twice. And the majority of the mutations within those categic regions are mainly C or C2G mutations. Another point I want to talk to you about is the intratumoral immune cytolytic activity. So for a CD8 positive cytotoxic T cell to recognize and target and kill its target cell, whether it be a virally infected cell or a cancerous cell, it has to attach to it through its T cell receptor along with its CD8 co-receptor, which recognizes the antigen which will be presented by the MHC class 1. And this CD8 positive cytotoxic T cell, one way with which it will kill is through the expression of 2 toxins called granzymes and perforins. So perforins will open pores on the membrane of the target cell, and granzymes will enter onto the target cell and will eventually lead to its apoptosis, so it's death, cell death. So measuring using RNA-seq data of these genes encoding for perforin and granzymes, the genes are called GZMA and PRF1. We can estimate the so-called immune cytolytic activity. And what with my team, what we did last year, measured the intratumoral immune cytolytic activity across all the different types of cancers, and we found that this varies a lot across these different types of cancers. Some cancers have high, some lower, and some other types of cancers have really minimal levels of immune cytolytic activity. This was measured both at the RNA and protein level. But in all cases, the expression of these 2 genes was concordant. So the key questions of this study is first, are there different mutational signatures between distinct cytolytic subgroups in colorectal cancer? Is categories associated with distinct cytolytic subgroups? And 3, sorry, these two, yeah. So first of all, activity in colorectal cancer. It was much lower in cancer, both colon and rectum, compared to the adjacent normal epithelium. And this was also verified using TMAs at the protein level. So we stratified cancers here at the bottom right into those that have high index of cytolytic, high cytolytic index and low cytolytic index. And we made comparisons between these two extreme subgroups of cancers. What we found is that the number of mutations, or the mutation load, in colon but not rectum tumors increased significantly given the high cytolytic activity. And it was also associated, it was correlated, cytolytic activity was correlated with the total number of mutations. Now, one could wonder whether our ability to analyze all these mutations is hampered by the tumor heterogeneity. So to address this, we measured the variable allele distribution for each tumor, and the width of this variant allele distribution is termed as mutant allele tumor heterogeneity. So this, or MAF. So this MAF score gives us, can answer whether there's heterogeneity or not. And what we found is that these MAF scores in the tumors do not correlate with the mutational burden, meaning that the mutations are not affected by heterogeneity. In addition, we didn't find any significant differences between the two cytolytic subgroups, which gives us a hint that the observed differences in the mutations
We cannot hear you. Sorry, I think we lost him, and we are trying to reconnect. So please, if you can wait 1 minute, please. So we are trying to reconnect with him.
I see your name that appearing.
Apostolos, can you hear me? Can you hear me from?
He left. He left.
He left?
No, he can't.
Sorry, we lost Dr. Apostolos, but almost done with his slides. So our next speaker will be Dr. Banan Mkhallalati, and Dr. Banan. Banan, can you hear me, Banan? Yes.
Yes, I can hear.
Assalamu alaikum. Yes.
Alaikum assalam.
That's great. That's great. So Dr. Banan is an assistant professor in clinical pharmacy in the College of Pharmacy since 2017. And also she is the founding assistant dean for faculty and student affairs and lecturer in 2009. So the title, her title, the speak will be about, she will speak about Practice Educator Academy, a fundamental step to experimental training success in Qatar. So, Dr. Banan, the floor is yours.
Thank you very much for your introduction. I will be sharing my screen now. Just give me a second. Do you see my screen? Okay. Thank you very much. Good afternoon, everyone, and thank you very much for attending this presentation. I would like to start by thanking the organizing committee of this symposium for selecting my topic for oral presentation. I'm the last one in this session, so I assume that I can have my time to talk, panelist. Okay, so I'm going to talk today about the Practice Educators Academy program, which is a fundamental step to experiential training success in Qatar. I have nothing to disclose. I would like to start by thanking the research team, and I would like to note here that this research is very interprofessional and intraprofessional collaborative research. It includes investigators and researchers from the 3 colleges in the health cluster, pharmacy, health sciences, and medicine. It also has collaborators from the College of Education, since it's a health profession education research, and it has collaborators. So it's very collaborative. From the College of Pharmacy, we have Dr. Ahmed Ouaissouf, Dr. Bridget Javed, Dr. Monica Zelousi, Ms. Sarah Al-Shami, and Dr. Rasha Basha. From College of Health Sciences, Professor Hiba Bawadi and Dr. Ghadir Jayousi, and from College of Medicine, Professor Marwan Abu Hajle, Dr. Iyad Al-Musleh, Professor Ali Sankar, and Dr. Susanna Hart. From College of Education, Professor Michael Romansky and Dr. Aranda Mahasne, and from Hamad Medical Corporation, Dr. Abdelatif Al-Khal and Dr. Christine Al-Ammari. So thank you for all of them for being part of this research. I'm going to talk today about, I'll give a little bit of background. I will talk about phase 1 of my research, phase 2 in terms of aim, objective, methodology, and results, and finally summary and future direction. As we all know that the best teachers are those who tell you where to look, but they don't tell you what to see. And that's why we conducted this research, because as we all know that experiential education is a fundamental component of health profession education programs. And clinical preceptors, who are the clinical teachers who teach our students in the practice sites, are indispensable in the experiential training of our students. Preceptors should ideally possess both clinical practice and teaching skills because they are teachers, but unfortunately, the vast majority of preceptors do not possess formal training as educators. They have been optimally trained as clinicians, but some of them, they were not trained as educators. And this brought me to apply for internal Qatari National Building Capacity Grant which I was luckily awarded with the name of Assessment of Educational Needs and Development of Preceptor Development Program for Health Profession Education in Qatar. And we chose the name of the Practice Educators Academy for our professional development program. For phase 1, the research aim was to assess the educational needs of preceptors, and after that to develop a preceptor development program. Our research comply with Qatar National Vision, a third pillar, human capital development, specifically in achieving an educated and healthy population by having well-equipped teachers in the clinical practice. It complies also with the National Health Strategy 2018 to 2022, which aims to deliver better health and better value for all. And finally, it complies with Qatar University Vision, which is to be recognized for its excellence in education and research, and having good educators in practice is part of that. We plan to achieve our research aim by the following research objectives: assessing educational need of preceptor, designing the Practice Educators Academy program, validating, and finally refining the program. For the first stage, which is assessing the educational needs, we did that through convergent mixed method approach by collecting qualitative and quantitative data simultaneously. For the qualitative phase, we conducted focus group, 6 focus group with students, 4 with preceptors, and 2 with faculty members across the health cluster colleges. And we came out with 5 themes: planning, delivery, assessment, feedback, and communication. For quantitative phase, we did a questionnaire. We distributed a questionnaire to 200 to more than 300 preceptors. We had 209 preceptors respondents. Response rate was between 62 to 65% among the 3 colleges, which is a good response rate. I'm going to share with you here a few quotes that we received through the qualitative phase, which indicates the need for this program. For example, in the theme planning, we had a biomedical student said, I will give an example. In one of the labs, the planning for one day is to do 2 tasks. These tasks could be finished in 2 hours. What I'm going to do for the hours? Just sitting in the lab and doing nothing? For the delivery and instruction theme, we had a nutrition student said, we have difficulty in linking what we learned with what we see in the practice. For the assessment theme, we had one of the preceptors said, lack of training and set standards, or at least the standards expected for 1-2 in the evaluation rubric, and how we are using these standards. And for the feedback, we had one of the preceptors said, it is difficult to evaluate because you are not getting any feedback from the faculty in terms of what we are doing. And finally, in the communication theme, we had one of the preceptors said, we need some workshops about dealing with different kind of students and different kind of situation. This will help us to deal with these students. And there are many, many quotes that identify gaps in the skills of preceptors. For the quantitative phase, which is a questionnaire, these are the demographic results in terms of experiences and teaching experience, rank title, nature of activities in precepting students. And this is the results for what preceptors perceive as their educational needs. And we have that the highest percentage of preceptors perceive that teaching and learning in clinical setting and mentoring skills and assessment skills as the highest priority. The majority of preceptors consider that the best way to develop their skills is through conferences, seminars, and training workshops, and they gave their preferences in terms of days of the week and in terms of delivery, and the highest percentage of preceptors preferred blended approach. Preceptors indicated that the highest motivational factors for them is the objective of the workshop, as well as the certification or the CPD points. Based on these needs, we started to develop the syllabus of the Practice Educator Academy. We formed a small group out of our research group, the big one, and we started to build the syllabus based on the preceptors' needs, and we benchmarked our syllabus with the international program. We developed a syllabus with the 5 modules: principles of learning and teaching, planning for experiential learning, teaching and instruction strategies, assessment and feedback, and finally communication skills and conflict resolution. And for each one of the modules, we managed to build learning outcome, very specific learning outcomes. And we benchmarked our syllabus, its modules and learning outcomes with the programs that are available in the globe that aim to also precept students, develop the preceptorship skills of preceptors. After we did that, we started to send our syllabus to scholars, local, regional, and international, to validate our syllabus and to make sure that it is a good syllabus. And we received very good feedback through the validation process. And these are some of the quotes that we received. For example, we have a quote about the learning outcome, not to use double action verbs, and to use action verbs that are measurable. And we refined our syllabus based on this validation step. So as you can see, we have changed and refined the learning outcomes according to the comments that we received. And this was the end of phase 1 of our research. And after that, I have also submitted a grant request for the National Building Capacity Grant with the name of Piloting and Evaluating the Preceptor Development Program for Health Profession Education in Qatar. And the aim of this phase was to develop the content of the Practice Educators Academy, pilot it, and then evaluate it, which again complies with Qatar National Vision, National Health Strategy, and Qatar University Visions. And the research objective of this phase was to develop the content, because we only in the first stage developed the syllabus, and to deliver this pilot, the Practice Educators Academy, to develop it as a pilot or to deliver it as a pilot, and after that to evaluate it. So as you can see, here are the modules. The speakers and the research collaborators from the 3 colleges have thankfully developed the content of the program, the 5 modules with 5 different lectures. And we managed to get an accreditation from the QCHB for the Practice Educators Academy as a workshop. Started preparation, so you can see these are snapshots of the brochure. We send announcements, invitations, and we have paired students with the preceptors, so we know which student is with which preceptors. And between the 23rd and the 25th, throughout 3 days, the workshop was delivered virtually. Thank you for the IT team in our college led by Mr. Shuja. We had 64 preceptors from the health cluster colleges attending, and we had 7 speakers from the health cluster colleges. As I said, this was accredited by Qatar Council of Health Practitioners, and it is to give the participants and the attendees 11.5 CPD hours for their attendance. These are some photos of the sessions. And I would like here to share with you a video that was like the opening remarks of Dr. Abdelatif Al-Khal, who is the Director of Medical Education and the Chair of the National Pandemic Committee, who was a great support for this research throughout the process.
It's my pleasure to invite you to the Practice Educators Academy, taking place from 23rd to 25th of October 2020 Clinical educators play an important role in the training and education of health professional students, acting as educators, mentors, and role models for students who will be the doctors, nurses, pharmacists, and allied health professionals of the future. The importance of clinical teachers is even more pronounced in today's challenging environment, as COVID-19 is reshaping health practice and changing the way we live, work, and learn together. The Practice Educator Academy is an innovative workshop, the first of its kind nationally and regionally, that aims to develop the teaching and learning related competencies, skills, and attitude of clinical teachers in Qatar.
So I will continue with my slides now. The third stage of this research, after it is delivered in October, is to evaluate the pilots, because this is the ultimate goal, that we want this to continue after evaluating the pilot. So we did a pre and post preceptor self-efficacy questionnaire. This questionnaire was given to the preceptors before, and it is given again to them now 2 weeks after the delivery, so that we see how they perceive their skills before and after. Also, for the students who are paired with these preceptors who attended the workshop, we gave them a masterate clinical teaching questionnaire. It was given to them before the workshop, and again this week after 2 weeks of the workshop, to see how they perceive the teaching skills of their preceptors. And also we did a workshop evaluation for all preceptors to see how the workshop was in their opinion. Also, we are planning to conduct some focus group with preceptors, probably after 2 months of the workshop, so that...
Dr. Mukhallalat, you have 2 minutes maximum. Thank you.
Yeah. 2 months after they have practiced their the skills that they have learned. With that, we will be completing the quality improvement cycle, which is act, plan, do, check, and again, after checking and after doing this evaluation, we will be acting to refine the workshop so that it is even a better workshop for educators. For future direction, of course, publication, we have already submitted for phase 1 manuscript to the Journal of Continuing Education and Health Profession, and it's under review, and we are planning to submit another publication after we finalize the evaluation of the pilot. We think that this workshop is going to be delivered biannually, and it will be the minimum requirement for new preceptors, hoping that by 3 to 5 years, all preceptors who teach our students in the health cluster will be at least equipped with this workshop. This is the list of acknowledgements for everyone who was a success factor in this workshop. My thanks to the Office of Research Support, for the research assistant and speakers and research team. And these are my references. Thank you very much for listening, and the floor is now yours if you have any question.
Thank you very much, Banan. So any question from? So I have a question about Banan for in general. This, it's not my field. About this Practice Educator Academy. So do you have, any members from outside Qatar, or of them from Qatar?
Thank you very much for your question. For the research team, it's all from Qatar. But as I said, from the 3 colleges plus Biomedical Corporation. However, in the validation stage for the syllabus, we have sent it to scholars from outside Qatar to take their opinion about the syllabus and about the program.
So are we planning to involve, somebody from outside? As
as educator?
As educator.
Well, it will be great. However, it's a resource extensive. This one, I mean, it's a lot of time and effort. So probably if there will be some kind of yani compensation for external speakers, for example, this might be a possible thing. However, our speakers did really great job because all of them have background in health profession education. And this was also supervised and not supervised, I mean, but collaborated with professors from the College of Education. So I think that we can be sufficient in conducting the workshop. And as you've seen that Dr. Abdulatif Al-Khal considered it as the first national and regional initiatives, which give me a great pleasure that he recognized it this way.
Yeah,
so I think that we can do it internally at this stage.
Okay, I agree. Very interesting. Thank you very much, Dr. Banan. Really appreciate it. Thank you very much. Thank you. Now we will move to another session. It's about COVID. And this session will be chaired by Dr. Fatiha. So, Dr. Fatiha will come.
Thank you, Dr. Asad. Thank you, Dr. Asad. So now we'll be moving to the third and last session of today. As Dr. Asad said, it will be focusing on COVID-19. We'll have two speakers. The first speaker is Dr. Professor Sui Fong Shai. I hope that I've pronounced your name correctly. He received his MD degree from Lanzhou University in China, his MPH from Hebrew University in Israel, his PhD from Basel University in Switzerland, and his MPM from the National University of Singapore and Harvard University. He worked at the China CDC for over 10 years, mainly in the National Immunization Program and the Division of Hepatitis. He then joined Beijing University, where he is currently the professor and head laboratory of science and technology, and the director of vaccine research at the School of Public Health. His research is mainly focused on infectious disease control, epidemiology research on vaccines and vaccine-preventable diseases, immunization intervention, international cooperation, and global health. He's also the author of over 260 scientific articles published in top-tier scientific journals in the area of infectious diseases. In addition, he is currently serving as an expert resource panel of hepatitis B in World Health Organization, Western Pacific region. He is the key person in leading the research team on the 10th, 11th, and 12th fifth-year plan of National Key Research Project of Science and Technology on Hepatitis Vaccination in China. So thank you for joining us, Dr. Fong Shi, and the mic is yours.
Thank you for invitation, Fatima. Thank you, colleagues, and thanks for his invitation. So now I'm going to share my screening. Can you share my? Can you see my screen now?
Yes.
Okay, good. So today I'm going to present you the latest development of the COVID-19 vaccine. So actually, this is I think most people are interested in how long it will take to have the safety and effective vaccine to combat COVID-19. And today I will give you the big picture about this topic. And as you know, there are more than 258 vaccine candidates in global and 52 candidate vaccine in clinical evaluation. And actually, there are 10 vaccine in phase 3 by 3rd November 2020. And you can see most of them are in preclinical, and there are only 52 in clinical evaluation. So I would assume that most of them will be maybe have more chances to succeed, but only maybe 7% will be succeed finally. And if you see from this slide that they use a different research and development routine. And you can see there are different routines for developing of the vaccine, like the RNA vaccine, DNA vaccine, and now replicating viral vector vaccine, and replicating viral vector vaccine, and inactivated vaccine, live attenuated vaccine, and protein subunit vaccine, and virus like particular vaccine, and others. So most of the vaccine you see, protein vaccine, maybe like more than 50 are in preclinical development, and only 7 in clinical development. And recombinant viral vector vaccine, there are 38 in preclinical trial, but only 4 in clinical development. And so there are a lot of the vaccine to be produced, but we don't know which one will be the most effective and safety vaccine in the end. And from globally, you can see there are almost six vaccines in phase 3 clinical trial. These are including three use a null replicating viral vector platform. One is from University of Oxford, and another from Gamaleya Research Institution, and also another from Johnson pharmaceutical companies. And 2 mRNA platforms were used to produce vaccine. One is from Moderna, and another from Biomedical. This is one of the vaccine in collaboration with Pfizer. As you know, that Pfizer make announcement several days ago to say they have the very good vaccine with more than 90% of the efficacy. And we haven't seen any of the more detailed information about how the data shows us. But this is just some news from the Pfizer. And we don't know if this vaccine will have very, very good, result as the news mentioned. If they really have more than 90% of the efficacy, that's really, really nice, because they reach the requirement developed by the WHO, says one of the vaccine at least should meet 50% of the efficacy. So we will waiting and see. So another protein subunit vaccine platform is produced by the Novartis. So this is the 6th vaccine in countries outside of China. But if you see, there are some vaccine also produced in China, and China uses 5 precellular technology routines in development. So we can see they use also inactivated vaccine, adenovirus 5 vector vaccine, recombination subunit vaccine, and mRNA vaccine, and attenuated influenza virus vector vaccine. So totally, there are 12 vaccines in clinical trial, but only 4 vaccines in phase 3 clinical trial. This is including the 1 vaccine from Casino Biological Company. They use the adenovirus vector vaccine, and 3 using the inactivated vaccine, 2 from the CMBG, and 1 from Sinovac. And if you see this slide that I showed, that's one in phase 2 study shows the adenovirus 5 vector vaccine with very good seroconversion rate at 96 or 96 after 28 days. So the higher dose has a very higher seroconversion rate than the lower dose, and with also the GMT almost reached 20. And if you see the specific neutralization antibody was observed as well, and with the antibody positive rate 90%. And also we see that this shows that higher concentrate dose, higher dose is much better than the lower dosage. And another vaccine you see another study shows that this adenovirus type 5 vector COVID-19 have the normal adverse reaction within 7 days. If you count any adverse event, that almost reach 80%. But if you look at the any events with more severe, we define as grade 3, that only maybe 6 to 70% with adverse event. And so if you see the serial conversion after 28 days, that actually like they reach the 97% and in for the low dose, and also 67 and 100% for the higher dose. And if you see the neutralization antibody for the greater than 4-fold increase, that actually 50% to 70% for the lower dose and higher dose respectively. So there is a statistical significance. And the study from Wuhan University, this is one of the vaccine, inactive vaccine. And this vaccine shows in clinical trial phase 1 and clinical trial phase 2. So the total adverse reaction is around 12 to 25 in phase 1, and 60% to 19% in phase 2. And the main of the adverse event are pain. So the pain account for 4% to 25% in phase 1, and in phase 2 that this account 2% to 14% in phase 2. And if you look at the neutralizing antibodies from the Beijing institution, one of the CNBG honored company, in phase 1 and phase 2 clinical trial, they found that the 2-dose immunization with 4 microgram vaccine in using the 2 and 28 days vaccination schedule with a higher neutralizing antibody titer than a single dose compared with only 1 dose use 80 microgram and the 4 microgram dose on day 1 and 14. And we can see that another of the company from the Sinovac shows that in clinical trial phase 1 and phase 2, actually the serum concentration is very, very higher, either at 14 days or 8 days after vaccination. And the coverage is almost 90 to 100%. And the GMT is also reached the 27 for the vaccination group after 14 days, and 30 around 30 after 28. So this is for the 14 days schedule. And if you compare the 14 days schedule, 1 14 days schedule and 1 28 schedule, the 28 days schedule is higher than the 1 and 14 days schedule. So the summary from the Chinese Kong vaccine shows the safety issue is tolerable within hundreds of samples, and the Norris vaccine has higher the slight fever, and this is some adverse event, and no ADE has been found in animal experiments. And for the immunogenicity, we can see the good immunity in different viruses, either higher positive rate for elixir antibody and the neutralizing antibody. So the different antibody levels we can see either is virus by the vaccine schedule or virus by the dosage. And the clinical trial of the phase 3 vaccine, you can see in active vaccine schedule for China, CNBG, honored Wuhan institution, there recommended 2 doses schedule, 1 and 14, and Beijing institution of the CNBG company, they also use the 2-dose schedule, 1 and 21 days. And Sinovac also recommended 1 and 21 day schedule, use 2 dosage. So that we can see the other vaccines from the international company like the adenovirus vector vaccine, like University of Oxford, they use a 1 dose schedule, and CanSino use 1 dose schedule, and Galamaya Research Institution and Johnson University, they recommended 2 dose schedule, but one is in 121 days schedule, and another is recommended 156 days schedule. And also for the mRNA and other vaccines, we can see the rest recommended 2 dose at 1 and 28 days. So this is some from the phase 1, phase 2, and some from the phase 2 plus vaccination clinical trial. But actually, there's some study using the homing challenging studies. So there is the long history to use this study. For example, these studies can accelerating the development of treatment for disease or vaccines. So from 1940s, the homing challenge study has been performed safely. And for example, the malaria vaccine, typhoid vaccine, cholera vaccine, norovirus, flu, and the Zika vaccine all has a history and experience using the home challenge studies. And you can see from the some countries, the USA and the UK and most countries use this kind of the research. And so this study, there are a lot of training study in COVID-19 in UK. So the target is to discover the smallest amount of virus to cause the COVID-19. The partnership with Imperial College London, University London, the Royal Free London and NHS Foundation Trust, and also their design is to have the study maybe finished in the next May. So the design is among the healthy young adults, and sample is up to 90, and strict control and the candidate. So the controlled interest to the facility and carefully demonstration of the waste and dedicated laboratory for carrying out testing, and air leaving this unit is cleared. So this is some requirement for the challenge study. So I think there is some requirement at least we have to reach for the vaccine development. This means that from the study shows that the efficacy of at least 70% to prevent the epidemic, and at least 8% to largely extinguish an epidemic without any other measures. And the WHO said it's almost success to benchmark for COVID-19. So the higher mark is called for 70% efficacy at the duration of protection for 1 year, with a lower threshold call for 50% for 6 months. So this is so we should to see that we must reach at least 50 for more than 6 months. So we don't know, but if this threshold for correlation between immunological indicator and disease protecting effectivity, and there are a lot of the comparabilities between the detection method, and so it is not possible to evaluate and compare vaccine effect only based on immunogenicity result. So once the vaccine is developed, it should first be quarantined to high-risk groups such as health work, elderly, and people with complications. So finally, mass campaign plans are well developed based on the national and global vaccine distribution and the severity of the pandemic. So this is, I think, there also the WHO and the government have the act to push the COVAX methodology and to access this vaccine in a very fair and transparent manners. So the access to the COVID-19 cure is produced, and there are a lot of the global international partners join to push this the vaccination development. So the COVAX I see is very, very good coalition joined by the government and the research and the pharmaceutical companies to join together, and then to make sure that this vaccine has equal access to all the peoples globally. So this is very good for people either in higher income country or lower income country can access this vaccine once it's available. So we need this COVAX because this COVAX can ensure the equitably sharing vaccine, and it is one of the three pioneers to access the COVID-19 tools accelerate, which was launched in April by WHO and European company and France in response to this pandemic. So being together, this government, global health organization, manufacturers, scientists, private sectors, civil society, and some other companies can, with the aim of providing now innovative and equipped access to COVID-19 diagnostic, treatment, and vaccine. At this moment, there are more than 190 countries joining this conflict. And I think there is some, because we don't have the bigger amount of the vaccine can cover all the population. So there are some scenarios for global response to COVID outbreak. So scenario one is assume that we have to have only 1 to 2% of the vaccine availability. And scenario two is to cover the 12 to almost with 12% of the population. And scenario three is maybe by 2021, we can have the 20 to 50% of the coverage for the population. So this is just assumption and scenario for assumption, but we don't know how many of vaccine we will have by the end of the 2021. So this is some a brief introduction for the COVID vaccine development. I would be happy to discuss with you and answer any questions you have. Thank you.
Yes, thank you very much, Dr. Fushan, for this very comprehensive talk. So we do have a couple of questions. So the first one is, should we trust Pfizer on their claim of 90% effectiveness? And what about long-term safety?
This is a very good question. And at this moment, because we haven't seen the article of the evidence published by the father in very detailed manner, we only heard any news from father. So we really don't know the safety and the effectiveness of this vaccine and the duration of this vaccine.
Okay. And then we have another question as well, which is, what about pre-existing immunity to human adenovirus vectors, such as AD5 and AD26, and how it would affect the efficacy of the vaccine?
I think this is also a very good question as well. So there actually this good question. Maybe we need some time to do the more detailed research to answer this question. And there are a lot of actually. So this question, as me, I'm always concerned about this issue, but I really don't know what is the result, what is the answer for this question. We need some time.
And just one final question from my side. So they did say the Pfizer that they're going to supply the vaccine in -80, and they're attempting to lyophilize it. Would changing the status of the vaccine affect its efficacy by any chance? So if you lyophilize it, would it be the same efficacy?
We don't know as well, because this is really a very good question. This is a very new disease, and also we have very new and the first time there are so many of the candidate vaccines, but which one is better than another one? How can compare with this is better than another one? So we need to have some methodology to compare. We also have to learn from any companion's experience and then draw as a conclusion.
Okay, brilliant. Thank you very much, Dr. Flushing.
Thank you.
I don't see any other questions. Thank you very much, and thank you for being here with us today.
Yeah, thank you for your name. Thanks for attention.
Thank you. So now we're gonna move to our second talk. It's someone from our own people, Dr. Hadi Yassin. He's an associate professor of infectious disease and section head of research at Qatar University Biomedical Science Research Center. He is also the chair of QUIBC committee. He serves as adjunct faculty in Hamad bin Khalifa University and previously in the Catholic University of America in Washington, D.C. His research interest and research expertise have been focused by several years of intensive work on, at state-of-art and multidisciplinary institutions. After earning his PhD degree from Ohio State University, He worked at the Vaccine Research Center at NIH for over 5 years as a postdoctoral fellow and then as a research fellow. Dr. Yassin has an excellent experience in the basic and applied biology fields, including virology, microbiology, immunology, molecular diagnostics, and vaccine development. He has published over 70 articles, which were cited over 3,000 times, some of which are in top-tier scientific journals like Nature, Nature Medicine, Cell, Lancet, Infectious Diseases. He is also serving on many committees at QU and other institutes around Qatar. He has participated in organizing several and local international workshops and conferences. He received several awards in recognition of his work and contributed to 6 patents on new design of viral vaccines. Thank you for being here with us, Dr. Hadi. The floor is yours.
Thank you, Fatiha, for the nice introduction, and thanks for the organizing committee for choosing me to give this talk. So the talk will not be about my actual work. So can you see the slides? Can you see the slides?
Yes, we can, Dr. Hadi.
Okay. So I will not be talking about my actual work in this presentation, but basically I will be summarizing about the different research activities that are running in Qatar University, not in Qatar. The original title was about research in Qatar, but that would be too much to talk about and comprehend in one session. So I'll be talking about the research activities in Qatar University. And the way I made this talk is that I will be talking a little bit about coronavirus in general, and then I will just summarize some of the research activities that are going on. And although there are a lot of good research activities going on, I could only talk about the published articles where I have access to the data. So I will just give brief description about a few articles from different colleges that are in Qatar University. So one good thing about coronavirus is that now pretty much everyone is aware about the importance of infectious diseases, because at one point there were not that much interest about infectious diseases in Qatar. But the emergence of coronavirus, as well as other emerging diseases like Zika, Ebola, swine flu, and others, highlight the importance about infectious disease and how we have to be prepared at any moment to face such outbreaks and pandemics. And just to brief you about coronaviruses are not new viruses. These are old viruses. They were first discovered in animals, especially in birds, in 1930s, similar to the story of cancers, which was first identified and recognized in chicken, and then it was studied in human. The same story for coronaviruses. They were first identified in birds in 1930s, but then they were isolated in humans, especially 2 coronaviruses were isolated in 1965. And we know for a fact that coronaviruses represent up to 30% of respiratory infection in human, although they generally cause mild symptoms, but they can cause lower respiratory tract infection. And myself, I had a bad experience with HKU1, which is a seasonal coronavirus. And the severity of the infection relies on many viral, environmental, and host factors in terms of host age, genetics, health conditions play a role in the severity of the disease. And we know also that these viruses are RNA viruses. They are the largest family of RNA viruses, and they are prone to mutation and recombination. And this might lead to escaping mutants that could be of high virulence and pathogenicity. In this slide, I'm just showing a timeline of human coronaviruses in specific. As I mentioned, the first 2 coronaviruses identified were the 229E and OC43 that were identified in 1965, and we call these old coronaviruses. But as you can see, starting from 2003 up to 2019, we had emergence of five coronaviruses. So these are becoming really common viruses in human. Starting from SARS that emerged in China in 2003, that affected approximately 10,000 people, led to the death of approximately 800 with a case fatality rate of 10%. And then between 2004 2006, we had the identification of two cold coronaviruses, or like common cold coronaviruses, NL63 and HKU1. There are some research showing that these viruses were circulating in the human population before, but they were only identified after people paid attention to coronaviruses after the SARS emergence. And here in our region, we had the MERS-CoV that it was first isolated in 2012. And unfortunately, the virus is still circulating in the camel population in the Arabian Peninsula. But fortunately, the virus has caused less than 3,000 cases worldwide. But the case fatality rate is a little bit high. It's much higher than SARS-CoV-2 and SARS-1, about 35%. And as you all aware of the SARS-CoV-2 that emerged in China in 2019, we have more than 40 million cases so far, more than 1 million deaths. But the case fatality rate could be between 1% to 3% or even lower. And we know that these viruses are of zoonotic origin. For the most part, they come from bats, but they require an intermediate host before they can jump and cause pandemics in a human. That was the case for SARS-1 and SARS-2. For SARS-1, it was hypothesized that civet cats were the intermediate host before the virus jumped in human. For SARS-CoV-2, they expect the pangolin or it's an anteater was the common or was the intermediate host. And for MERS, it was the camel. And these coronaviruses are divided into different subfamilies or groups, mainly alpha and beta and gamma and delta. Two of them, the 229E and NL63, belong to the alpha coronaviruses. The SARS-CoV-1, SARS-CoV-2, the MERS, HKU1, and OC43 belong to the beta coronaviruses. So this is a brief introduction about coronavirus. And then, as I mentioned, I will just brief a little bit about the research activities at Qatar University. I would like to thank Dr. Gerhild for providing me with some of this information, especially this table that summarize the number of research articles and grants that have been awarded or published from Qatar University. And here, the number of articles is divided or like a group as per the centers or the colleges in Qatar University. You can see that within a very short period of time, we have published more than 46 articles. And the emergence of this coronavirus has ignited a lot of research activities in different sectors. And thankfully, that resulted in a lot of publications. There are a lot of publications that are in the pipeline, 16 submitted, 25 in preparation. In a very short period of time, we were awarded as PIs at Qatar University around 26 grants. Internal grants from Qatar University as well as external grants from QNRF. There are still other grants in pending, and we have more than 40 projects that are ongoing. And this is just the distribution of articles among colleges and research centers. I just want to note here that the published articles were either reviews, systematic reviews or surveys or original articles. So they were diverse in the types of article being published. And many of these were authored by Qatar University, like the one in blue in color, or co-authored with other institution, which tells about the collaboration that's going on between the different colleges and different PIs at Qatar University among each other, as well as the PIs from other institutions. And if you look at the research team, there are a variety of research activities were going on. So we have artificial intelligence and in silico analysis. We have a few guys, including, for example, Dr. Hatim from College of Health Sciences that relies a lot on artificial intelligence. We have a lot of systematic reviews and meta-analysis, like like people from College of Medicine, College of Pharmacy, COVID-19 and chronic illnesses, pharmacotherapy. We have a lot of activities in terms of sequencing and studying the virus evolution, genetic susceptibility to COVID-19, so on and so forth. So I will start now about like just presenting samples of published articles by different colleges and each center. I will start with the College of Medicine with this article published or led by Dr. Suhail Dewey. And as I mentioned, I'm not gonna go into very deep scientific details. I'm just gonna brief about the outcomes. And again, I just selected the articles that were published because I did not have access to the non-published article, and also because of the data not published. So this article, you know, like there were a lot of talk about the efficacy of hydroxychloroquine in treating COVID-19 patients. So in this article, Dr. Suhail Dewey and his team did a meta-analysis review to analyze the efficacy of chloroquine and hydroxychloroquine in treating COVID-19 patients with or without azithromycin treatment. So in this meta-analysis or systematic review, they had more than 40 studies included, comprising more than 100,000 participants. And there is inclusive evidence that chloroquine and hydroxychloroquine with or without erythromycin were not effective in treating COVID-19 or its exacerbations. So another article published in collaboration between Dr. Naila Rabbani from College of Medicine and Dr. Paul from QBRI. And this one, they used artificial intelligence, and the title of the article was Vulnerabilities of SARS-CoV-2 Virus to Proteotoxicity, Opportunity for Repurposed Chemotherapy of COVID-19 Infection. And the whole idea of this article was to explore if reactive metabolites of the host can be exploited to produce a virucidal response against COVID-19. So they did a series of studies using bioinformatics tools available, proteomic data and cell model used for SARS-CoV-2 propagation. And then they predicted the susceptibility of SARS-CoV-2 to reactive glycan agent, methyl glyoxyl. So basically this compound, the MG, can modify the arginine residues that are found in the furin cleavage site of the virus and inhibit the virus. So this work, as I mentioned, was done in silico, but I know Dr. Naila is already doing in vitro analysis, and there are some promising results regarding this drug. The third and last study that I will share with you from College of Medicine was led by Dr. Saghir Akhtar and Dr. Abdullah Habib from College of Medicine. And in this one, they reviewed studies implicating 14 classes of drugs in increasing ACE2 levels, which we know that this is the receptor for SARS-CoV-2. So they reviewed implicating the increasing level of this receptor and the available literature on clinical safety of drugs in clinical patients. And they found that, according to the literature, that ACE2 inhibitors and angiotensin 2 receptor blocker appear to be safe in treating COVID-19 patients, but they could cause increase in acute renal injury. So now I will jump to studies from College of Health Sciences. This study was done by Dr. Hatem, where he performed comparative analysis for transcriptomic signatures of COVID-19 compared to other respiratory viruses as well as Ebola. And they identified for the first time several molecular pathways associated with SARS-CoV-2. And the main finding is that virogenomic transcriptome of the infection, gene modulation of host viral response were similar between Ebola and COVID-19, but different from SARS, H1N1, and MERS-CoV. And another study was done by Dr. Zoomin to investigate the association between stringency of COVID-19, social distancing, and mental health outcome. This was also a review-based article, and they found that as the stringency of public health measure increases, the depression and worries increases, and that observation was higher in women compared to men. Another studies from Dr. Ghiath from College of Health Sciences. I know Dr. Ghiath, he is running a lot of analysis in comparing different serological techniques to detect antibodies against COVID-19. So he's evaluating manual as well as automated machines in terms of measuring the antibodies. And in this study, he compared 5 commercial ELISA and he tested samples coming from different patients with different clinical outcomes. And as a conclusion, he found that the kit that measure antibodies specifically to the spike protein S1 demonstrate higher performance with higher specificity, and it has very minimal cross-reactivity with other human coronaviruses. Jumping to the studies from College of Pharmacy, they did a lot of great work in terms of surveys, and in this one they used social listening technique to explore unfiltered public perception of professionals involved in healthcare teams during the COVID-19 pandemic. So a cross-sectional retrospective reviews of comments on specific social media, including Facebook, Twitter, so on and so forth, was done between 15th of March and 28th of April. And they identified a lot of posts and a lot of comments. And the conclusion was that the current COVID-19 pandemic and media attention should be taken as an opportunity by the interprofessional community to work together to combat negative media stereotypes. As you know, that the media produce a lot of wrong messages, and we have to be aware of how to combat these wrong messages. A very important study done by College of Medicine. So in addition to focusing on this survey, they also have some implication in the clinical aspect where they introduced a hospital drive-up anticoagulation testing service. And this service can reduce the risk of exposure of anticoagulation patients to COVID-19 by reducing the contact time with the different personnel at the hospital and by maintaining those patients as a safe distance from each other. We also had several articles published, one of them about the impact of COVID-19 on maternity and young infants, as well as they have very important study titled as an emergency switch to distance learning in response to COVID-19 pandemic. As we know, there are a lot of classes given online, and they use their experience from an internationally accredited undergraduate program at pharmacy to analyze or to predict the outcome of such social distancing learning among our undergraduate students. Finally, I will summarize a little bit about what we are doing at the Biomedical Research Center. I just want to highlight that here that we have the first biosafety level 3 lab for research purposes at Qatar, and thankfully we had it on time that we can use during this COVID-19 pandemic, and this is a mobile facility that can be transferred anywhere in the nation during the outbreaks. So one of our capacity is sequencing, and we have 2 platforms, the Illumina platform and the Oxford Nanopore platform. And with the help of Fatiha and other people in the center, we were able to sequence more than 500 isolates. And these were the sequence from patients with different demographic and clinical outcomes. And as you can see from the upper figure here, although we had multiple introduction of the virus, and during the peak of the virus in Qatar between mid-May and mid-June, we noticed an increase in detected lineages that continue to circulate in Qatar. These are other research projects conducted at the BRC. So we are doing in evaluating the response of the virus to antiviral drug using in silico analysis as well as in vitro work, whole genome sequencing of the virus, as I mentioned, evaluating unconventional, new, robust, and high throughput diagnostic techniques like LAMP, and again, this is led by Fatiha, studying the immune response of the virus in different population, including ADCC neutralization, and we have multiple neutralization platforms currently available in the BRC. Study the virus studied the disease at the host site by studying or identifying host factors that increase the risk of infection and complications of the infection. And this is just a summary of 3 different papers that were recently published. And just want to mention that we have been working with coronaviruses even before the COVID-19. This study was done between me and Dr. Riyad from College of Health Sciences, where we surveyed for the seroprevalence of MERS-CoV in Qatar population, and we found very low prevalence. Another study that was led by Hiba Al-Khatib in our center that studied whether the virus diversity within COVID patients have any effect on the severity of disease. Although we did not find a clear viral genetic signature that can differentiate between severe and non-severe disease. However, we noticed high diversity of the virus in the severe patients. So it seems the virus is mutating more in the severe patients. Another study was done by PhD student Maria Smati, where she studied the host genetic variants potentially associated with COVID-19. And she found that Qatari genome, according to the Qatar genome data that we have higher frequency of variant associated with susceptibility, but not the severity of the disease. Before I finish, I was also to mention that we did a lot of work in testing SARS-CoV-2 in animals and environment. Fortunately, although we detected some PCR positive samples from cats, dogs, and camels, but these were high CT values, more than 30. And we were also involved in environmental screening of samples, including clinical environmental samples, air sample, and wastewater treatment plants. By this, I would like to thank you for listening and thank all of our collaborators who pretty much collaborate with different stakeholders in Qatar in the government and academic field. So thanks for everyone. Thank you for listening, and I welcome any questions.
Thank you so much, Dr. Hadi, for showcasing the efforts that are led by the scientists at Qatar University. I mean, it's very impressive, and I hope that in the near future we'll even have more papers out, that represents Qatar. So I don't see many questions. I don't see any questions, actually, but I have just one question from my side. So we were fortunate for not having a high death rate. So we were the second country with the lowest death rates due to COVID-19. And you just mentioned that the paper published by Maria, that the Qatari population have lower susceptibility. But then I think it was targeting just the Qatari population. Do you think it's the same context for the rest of the population, or what is the reason behind it, or if there's any studies that sort of tackled it in terms of treatment regimes or anything of such?
So thank you, Fatih, for the question. So as you mentioned, Maria's paper was only based on the sequences coming from Qatar genome, and these are mainly for Qataris and long-term residents. And in terms of infection, most of the infections in Qatar occurred in worker camps, and most of these are expats. But the low death rate, it's most probably because of the younger age of these patients. So, and we know that the age plays an important role in severity of the disease. The other thing, I think the healthcare system in Qatar is very well advanced, and they are like using a lot of resources, and they are not being stingy at all in providing any type of care and service in order to treat the disease in these patients. So I think like we have two factors in that regard.
Yeah, thank you so much, Dr. Hadi. Thank you. I think we'll wrap it up at here because I don't see any more questions. Thank you so much. I'll give the floor to Dr. Firas now for the award session.
So now they can hear me, right? Okay, so thank you so much, Dr. Fatiha. Thank you so much, Dr. Hadi. I really enjoyed this afternoon session. Thanks everyone for joining through the day. I'm really impressed that still we have 80 people. Like we started with almost 120 people, and for 80 people to stay with us till this time, I think this is very good outcome. I also enjoyed all the lectures and the discussion that went today. And I would like again to thank everybody who contributed to this, and for all of the attendees, postgraduate students and faculty alike. I think we will just be sharing with you the awards winners per the different categories. And those are like financial, not that big of a deal, but still it's quite good recognition for all. So for live oral faculty presentation, first place winner is Dr. Mohammed Al-Rais from PRC. The second place winner is Dr. Banan Mukhallalati from pharmacy. Okay, for our poster presentation, faculty poster presentation, our first winner is Dr. Hussein Yilsen from PRC. Second place is Dr. Naila Rabbani from CMID. Okay, for postgraduate presentation, first place winner is Ola Hussein from pharmacy, supervised by Dr. Ashraf Khalil. Second place winner is Dua Sadiq, supervised by Dr. Ghayath Nasrallah. And the third place winner is Muhammad Abdul Ali, supervised by Dr. Dawood Badriya from pharmacy. Last category is the students, undergraduate students. And those are, we have Aisha Al-Khalaqi, Fatma Naimi, Rawda Qasim. I don't see the rest, Shuja, because can you move this? This one is covering. Sorry. Okay, so Rawda Qasimi, supervised by Dr. Hiba Bawadi from CHS again. And, second place winner is Sarah Saidi, Aish Hana Dahir, and Ola Muhammad from CHS, supervised by Dr. Tahir Al-Ubaid from CHS. And last third place winner also is El-Jighifi and Ruba Abdin from CHS, supervised by Dr. Ghayath Nasrallah. So congratulations all faculty, postgraduate, undergraduate students. Thank you all. I mean, this has been an amazing day. And thank you all. Thank for the organizing committee, judging committee, ITV, ER, my office, Dr. Gerhard, and Ms. Sana Al-Ajuri. Thanks everybody. Thank you so much. Okay, see you guys. Thank you so much. Thank you. Thank you all. I think it's good. Thank you so much. Shuja, I mean, this can't be without you. I can't thank you enough. Thank you so much.
Thank you for your support.
We need to clone people like you, Shuja.